Good morning to most those on the East, and thanks for our, on the West, and thanks for our East Coast commissioners and listeners joining in. Good to be with you again here for the August 25th meeting of the Healthy California for All Commission. Commissioner, I'm the chair. I'm Secretary of Health and Human Services, Mark Galley. And proud to facilitate what I think is going to be another really lively and important conversation in our journey towards our end product. Excited about the speakers we have lined up and the topics and the discussion. But before we get into it, and I make some other opening comments around important housekeeping, but more substantive issues as well, Karen, can I turn it back to you to go over our Zoom protocols and then also dive right into roll call if we can?
Yes, thank you so much, Secretary Galley. Good morning, everyone. So just briefly to go over our Zoom protocols, a reminder that this meeting is being recorded. Commissioners, as you know, you have the ability to mute and unmute and the option to have video on. We appreciate that that you are doing so we can all connect visually. We ask that you do keep yourselves muted when you're not speaking, just to reduce the background noise. If you'd like to speak, you could use the virtual hand feature at the bottom of your Zoom using the reactions icon. I think it's been the custom most recently for Secretary Galley just to ask folks to unmute or to call on you, so be prepared for that as well. Members of the public, welcome. You are in listen-only mode and are able to view the meeting. We will be inviting public comment at the public comment periods during this meeting, at which time we will open up the chat feature for real-time written comment. We will also be inviting members of the public to speak verbally as well. And you can always email written comments to healthyca@chhs.ca.gov. We will be considering all public comment during this meeting public record. We also have the live transcript mode enabled during this meeting. So at the bottom of your Zoom screen, you'll see an icon called live transcript. That's closed captions. All right, now moving to roll call. Commissioners, if you wouldn't mind when I call your name to unmute and say hello. We'll start with the chair, Secretary Galley.
Good morning.
Carmen Comsty.
Good morning, everyone.
Jenny Chen Hansen.
Good morning.
Bill Shao.
Good morning.
Rupa Maria. Okay, we'll be on the lookout for her. Bob Ross, have you been able to join us yet?
Yes, good morning, everyone.
Good morning. Richard Scheffler.
Good morning.
Andy Schneider.
Morning.
Sarah Phlox.
Good morning.
Kara Desert.
Morning, everyone.
Antonia Hernandez.
Good morning, everyone.
Anthony Wright.
Good morning, all.
Richard Pan. Okay, we'll keep a lookout for Senator Pan. Jim Wood.
Good morning.
Will Lightbourne.
Hello.
Good morning. Peter Lee.
Howdy.
Don Molds.
Good morning.
And Sandra Hernandez. I saw that she was with us, so and I can see her there, just not unmuted.
Yeah, she had let me know she may not be able. She's in a strong listening mode, which I appreciate.
Wonderful. Okay, and of course we'll keep an eye out for other commissioners and mention that on the chat when we see that they've joined us. All right, Secretary Galley, I turn it back to you.
And Karen, can you hear me, Karen?
Yes.
Okay, perfect. Dr. Pan just let me know that he's here, but we're not able to unmute him. So
okay,
we'll keep, Richard, if you can keep trying to unmute yourself and give us a thumbs up, or let me know when you're in so we can pull you in. But glad, oh, there we go. Good, glad that all the commissioners can listen in. Again, I'm just looking at the Zoom. We have almost 200 participants overall, so another rich conversation that I'm looking forward to. Want to start by just sort of previewing where we're going to spend our time today. It's really going to be about accountability and systems of accountability and how we use those systems to assure quality, equity, and access. Some of those, the pillars that we've been talking about the whole time. We're also going to look at behavioral health, building on what Sandra Hernandez, Commissioner Hernandez, offered up in our last meeting, a deeper look at where we are in California with behavioral health in particular. I'll be honest, we debated, was it behavioral health that we looked at it? Was it public health and population health? These two sort of parallel systems to the broader physical health medical system that often doesn't integrate those other two things. We chose to go with behavioral health. So happy to have a presentation about the current state of affairs in California and less focused on those details of how it's going today, but more on the structure of behavioral health and how a unified financing system would really have to grapple with and think through bringing that together in an integrated way. But before we go into those topics, and the speakers, your co-commissioners who are lined up to help lead that, I wanted to talk a little bit about our schedule coming up on the 21st of September. I'm excited. We'll have a webinar to discuss the preliminary findings of our community engagement work. You'll remember that 3 of our commissioners and the foundations that they lead, Sandra, Antonia, and Bob, came together to help fund and put together, and more than fund, really help guide with other commissioners' input, community engagement effort that has 3 prongs. I'll go into that in a little bit, but we'll have a chance to hear about the preliminary findings on September 21st. Then we have our pre-scheduled September 23rd meeting. And then we added the special session on September 28th. I know it's a lot. I know it's all happening in a short amount of time, but we wanted to add this issue that grateful to Rupa and Bob and Sandra and so many other commissioners who chimed in and said, look, we need to have a special meeting regarding racial equity in healthcare and how the system of the future that we will consider will incorporate our best thinking. So I think we're in a good place to respond to those commissioner concepts and ideas and the thirst for more on the issue. Next slide, if we can advance it. So I wanted to talk a little bit, this really gets back to where we are with our thinking on the final report. I talked to you previously that we would provide, and we have summaries of the meetings that have happened to date. Those summaries really try to glean common themes, directional comments or discussion points for commissioners to sort of validate and really think and build upon. And I also talked a while back about the aspirations of having a report that kind of did, on one hand, some commissioners said this, and then on the other hand, other commissioners said that. I think given the progress we've made in the last couple of meetings, I'm going to be bold enough to suggest that maybe we take a step farther than that in our aspirations with the final report, and we actually look at common goals, values, and propositions. So I've asked the consulting team with Vishal and others at HHS to really begin to galvanize around these themes. We will be working to put together a survey that will go out to commissioners with some of these goals and values and propositions to get your initial feedback, to fill in some gaps or holes. This is not meant to be an exercise where we introduce all of the other things that we haven't gotten to talk about in the commission meeting. It's really meant to deepen our thinking on the things that are on the page. We will see how this work goes, but I do think it's going to be important, given our tight meeting schedule, our ambition to really provide as much input as we can to have this iterative process in these different areas. So expect soon to get that survey, and we'll gather it prior to the September meeting. We will wait until after the team has some time after this meeting to make sure it really captures 3 meetings worth of summaries and information, and then send that around. If at any point you feel like, hey, this isn't heading in the right direction, I'm always happy to take a quick call on it and hear what you're thinking. But this is our stab at trying to really push a little deeper. And I think if we can, and these are my words, this is feedback I got from somebody else, but I liked it that I'll say it. A report that sort of looks at it, if we decided to move to a single payer unified financing system in California, our report should be able to say, how would we do it? This isn't necessarily going to focus on should we do it, it's the how would we do it, not focused only on or primarily on how do you finance it, where does the money come from, how much, but really the how. And I know those are conflated in some ways, certainly, but I look forward to trying to push us a little farther in that direction. And I think that that certainly resonates with a number of you who want to make sure that the work of the commission is not just rich, good inputs once a month, but that we build a document that can be really useful in the future. So stay tuned, more on that, but I wanted to give you that update on some work that we'll be thinking about in the days and weeks to come. If we can go to the next slide. I also want to acknowledge that I'm grateful for everyone's thoughtful input. We've received many commissioners' input on the analytic methods and assumptions that were made. We did get a few points of feedback that we put into buckets. The first one is really, hey, it's too early to really build on these specific methods and assumptions, that we needed more time to discuss and design those. We're cognizant of that, and will, of course, as the commission deepens our conversations, themes come up, we'll be thinking through and giving ourselves opportunities, even in those goals and priorities conversations that we send around. We might glean some specific tweaks to this that are important. So we'll be on the lookout for that. We also received feedback that the analysis should include different assumptions. It's similar to the first comment that, you know, as we have these conversations, we will make sure that we're watching closely whether we have significant or material enough change to go back and reassess some of those methods and assumptions that were made and tweak them. And then that we want to make sure, and we'll be on the lookout for this as well, that the concerns for further clarification about the methods and assumptions used to estimate the effects of unified financing, that we want to keep ourselves honest that those were the right ones, that they were a complete set. So again, to validate that we receive this important feedback, that we take it to heart, take it into account, plan to keep you know, road testing where we've been, and as we move forward, if there's material need to tweak those as we go along, we will do it. I also just want to be cognizant of how much and when we put new work on the consulting team, which I have to manage the time and availability of what we're able to do. So I want to keep a close eye on making sure we go to the well of tweaking this and rerunning things only when we have you know, good sense of suspicion that it's going to make a material difference. So I know this isn't the end of this conversation. I just wanted to spend a minute acknowledging the feedback, telling you where where we are on it and the fact that, like all things in this commission, we will continue to iterate as needed. Next slide, Karen. So let's just talk. I alluded to the community engagement update. I wanted to really thank the commissioners. I know Rupa, you I think have joined now. Thank you for joining. That your feedback was important here. Just wanted to tell you that through the work of the foundations, through the work of our team and Bobby Wench and others, they're deep into the work. This is not like it just got started. We have been gathering perspectives from a number of residents of California, people below 250% of federal poverty, trying to amass a diverse set of opinions and considerations on what's important for healthcare to work for those populations. Really trying to ensure that we pull in the voices that often either are overlooked or frankly not heard in some of the policy discussions. So really looking forward to our upcoming preview of where they are. I just wanted to take a moment to tell you some of the groups or some of the different aspects that have actually been undertaken already. I believe they've done a random sampling of about 1,500 Californians, as I said, all below 250% of FPL. These interviews have been done by phone, online, lots of invitations sent to a diverse number of Californians, not all done in English, done in other native languages, drawing in an attempt to overrepresent communities of color that have certainly been historically involved in some of these policy discussions. They also held a series of online discussion boards that I think we'll learn how well attended they were, but both in English and Spanish. And then working directly with some of the community-based organizations that often become the front line, the front door for so many of underserved and overlooked Californians in different parts, both rural and urban California. So those 40 organizations represented, I think, a number of individual groups that were recommended by some of the commissioners here. And I'm grateful to have that chance to hear what the summary is of their findings, and we'll get that chance to discuss it in the webinar on the 21st, and then make some time in our September 23rd meeting to make sure we have additional opportunity to distill it and think about what we heard. So I'm grateful again to those who funded the effort, those who put it together, and I know many of you have been wondering where this is, and by the end of the month, we'll have a better sense. Okay. Karen, can we keep going? All right. So in a rare case of efficiency, we are 10 minutes ahead, which I'm very grateful for, because that might mean breaks actually happen and we have more time for the rich discussion. So first, I wanted to, in advance, shout out and thanks to Commissioners Fox, Scheffler, and Lightbourne, who all graciously, like our colleagues before in the past two meetings, graciously accepted the invitations to present. I think that the bar keeps getting set higher and higher. So I've no doubt that today's presentations and the conversation that ensues will continue to move us in that direction. So yes, those of you who are asked to present in the December meeting, good luck, because the bar will be pretty high, certainly by then. So the two topics that we're going to focus on, as I said before, systems for behavioral health integration and accountability. And the second one is systems of accountability to assure improved equity, quality, and access. And I'll just begin by saying, because of some scheduling issues, we had originally wanted to start with Sarah and Richard's presentation and close out on the behavioral health issue, in part because I want to make sure we had a chance to contextualize some of those accountability concepts as it relates to the challenge around behavioral health. Unfortunately, we had to flip it, and I think it's fine. It's just going to require me to be a shrewder facilitator to make sure that we budget time. So I'll just say in advance, if I cut you off or move us along faster than you'd like, you'll be grateful I added 10 minutes at this front end, but it still might be required to make sure we have enough time on both of these meaty topics. So I wanted to, I'm sure that all of you did the same thing that I did, but we're kind of using accountability as a word to apply in a lot of different areas and venues. So I went ahead and just looked it up to try to figure out what do people mean by accountability. And the best definition I saw was, and I'll just read it, when an individual or an entity experience consequences for their performance or actions. And so I ask us to kind of keep a basic definition of accountability in mind when we're walking through the presentations and we're thinking about today. And I'll just put up front some of the issues that we as a team talked about that I think are also important when we think about accountability. And it's, you know, who is being held accountable and who are they accountable to? What are they accountable for? And then what are the levers to assure accountability? I'm going to repeat them quickly so we can keep them in mind. Who is accountable and who are they accountable to? What are they accountable for? And what are the levers to assure accountability? And as I was thinking about this at sort of the next level down, and I think about what are the levers or what are people accountable for, I'm sort of reminded around, well, are we accountable for delivering high quality health or health equity? Or are we accountable to a cost target and something to do with, you know, the true cost of care? And I mean, obviously the answer is not one versus the other, but I do think that it's going to take us some, you know, deepened and back and forth conversation about some of these key questions, even in light of what I think will be some specific conversations by Richard around his presentation, focusing on risk-based capitation, the use of integrated systems to deliver on equity, and some of the focus on how those tools and systems deliver on accountability or create a structure of accountability that could be useful for us as we think about the future models. And then as we get to Sarah's conversation around those levers of accountability as well, and the use of payments as a tool for accountability, as a driver of accountability, and then how we distribute some of our resources based on that, in particular our staff and workforce resources to deliver on accountability as well. So just ask you, as we jump into these conversations, to keep that front and center. But that sort of, you know, it should apply to all three of the presentations. But as I said, we want to start with Director Lightbourne, and he's invited, rightfully so, our Medicaid director, our state Medicaid director, JC Cooper, both working hard, not just on COVID, not just on our waiver negotiations with the federal government. They're very, very busy at the moment. Not that they aren't at other moments, but really am grateful that they took time to prepare and kind of help us get started in a conversation as it applies to behavioral health. So with that, we can probably advance it, and I'll turn it over to Will and JC to get us going.
Thanks, Mark. Let me sort of start. The way we're going to organize this is my colleague, JC Cooper, will sort of do a walkthrough of how we have the behavioral health system in California structured, certainly on the public side, and most of it is on the public side. After JC's done the walkthrough, I'm going to take a few moments to sort of frame and shape what I think may be some of the issues and questions that we will need to keep in front of us as we continue to envision a unified financing system as it impacts the behavioral health delivery system. So with that, JC, why don't you go ahead?
Sure. If someone could progress the slides to the first slide of the presentation.
Sorry, JC, you're having a little technical difficulty. We apologize. We'll be right with you.
Okay. I can probably go ahead and get started if that's helpful, just starting with some context as you're working to get the slides forward. And I will say thank you, Mark. The scheduling change was because of me. I'm actually presenting at the Mental Health Caucus later, so very a hot topic, to say the least, these days in regards to behavioral health, and appreciate everybody accommodating that change. You can go to the next slide. To 15 if you can get there. So DHCS is the single state Medicaid agency, as some may be aware. I will be keeping my overview really within the context of what the Department of Healthcare Services oversees. Obviously, there's additional behavioral health services provided through private entities and plans, but just for context in regards to some of the large pieces across behavioral health. The other thing I would point out is the landscape really changed back when the Affordable Care Act was passed. Previously, almost all behavioral health services were primarily carved out and provided through our counties, especially for adults and indigent adults in that case, as well as, really changing the way that we divided our behavioral health services in California back in 2014. So California did elect to adopt, optional benefit expansion that really expanded the depth and breadth of the behavioral health services that we were providing in Medi-Cal. It also changed the players in regards to who was providing those services. And so now you'll see here that there are, a variety of delivery systems that are providing different types of behavioral health services within the large delivery system. We have managed care plans. We have a portion within our fee-for-service Medi-Cal program. Of course, the counties play a significant role in regards to specialty mental health, as well as all of our substance use disorder services. I'll get into that a little bit later. But there's also, in addition to that, we have a number of what we call community services, and that is the services provided through various mental health or substance use block grants from the federal government, as well as MHSA dollars. So there's a lot of different parts that feed into the landscape of the behavioral health services in California. Next slide. This is just to give context to the commission in regards to the current dollars within the DHCS system. It is slightly old. It's of March of 2020, but was what we could pull for purposes of the presentation today, just to give some context of, the revenue from realignment. We have MHSA, or what's known as Prop 63, the state general fund, and then federal funds, of course, included in there as well. And that is a split between our county behavioral health partners and then our Medi-Cal managed care, of course, an additional portion in our fee-for-service environment as well. And that would, in addition to this, would be a few $100 million within the block grant pieces mentioned earlier. So just a snapshot, just so people have an understanding of the magnitude of, at least within the DHCS area. Next slide. So one of the pieces to just make sure the commission understands the way the mental health services were implemented in 2014, since the counties had the historical obligation around specialty mental health and SUD services. The way that to come into compliance with the Affordable Care Act and the essential health benefits, the way that the mental health benefit was implemented is now slightly, bifurcated. So our Medi-Cal managed care plans are responsible for providing what we call non-specialty mental health services, or also known as mild to moderate mental health services. You'll hear both of those terms used in California. And it really was around identifying adults who need mental health services that have a mild to moderate distress or a mild to moderate impairment, that those would be provided by the managed care plans. And I'll kind of walk through the benefits that they provide, but it's essentially the lower level first intervention in the primary care office or with the behavioral health provider, providing that first intervention level of services. Once someone gets to a level of a higher impairment or distress, then the specialty mental health is where it kicks in, and that is the responsibility of the counties. As you would imagine, this does require handoffs between our mental health plans and our county partners, bidirectional oftentimes, especially as someone stabilizes, there often can be transitions between. And so that, that has created a lot of conversation over time in regards to that split. We don't see that typically within healthcare. We actually had a conversation about this the other day where it'd be like starting with someone who, your preventative services are in one area, your management of diabetes is one area, and then you're completely separating off to a completely separate delivery system, financing structure for the overall management once somebody gets into a higher acuity or even a non-compliant state. And so that continuity is important, but just something for people to understand in regards to how we split the non-specialty and the specialty mental health services. One thing to also note, under federal law, anyone under the age of 21 should be receiving all medically necessary services. It's an important piece. It's called EPSDT. It's something we know very well on our side, but I think it's important context in regards to the delivery system and the fact that we need to do better at earlier preventive intervention services for children across both our managed care plan and mental health. Even though the services are split, both have the obligation of providing all medically necessary services within their defined benefit structure. So something just as you're thinking through accountability and structure and concepts today, just to make sure you are tracking, there is different expectations for anyone under the age of 21 versus adults in federal law. Next slide. So this is just to give people a context to the various specialty mental health services provided through our county partners. I'm not going to read the list, but you're going to see there it's the higher acuity services. This is your crisis intervention services, your residential treatment services, your inpatient services, of course, wrapped with a number of mental health and medication support services to be able to provide those comprehensive services at the higher acuity level. Next slide. On the substance use disorder side, just a few pieces to make sure people are tracking. We currently in California have our substance use services separated into two different models. A majority of the lives are receiving it under what we call our drug Medi-Cal organized delivery system, where it's more of a comprehensive benefit, has additional services available. But we do still have some counties who are providing just the drug Medi-Cal treatment program. It is a slightly smaller benefit. For the SUD services, it is one that the counties have to elect to move from the DMC to the larger piece. It's just important context to understand that there still are various levels of access to the SUD services depending on counties across the state of California, and that counties have to elect because of the various financing and different pieces have to elect to go to that additional level of services. That's really where you're going to get into some of your higher intensive outpatient services, your residential services, recovery services in that larger package. Regardless of where, the types of services available in a county, all are within and shall be using criteria adopted by the American Society of Addiction Medicine, or what we call ASAM. And that's standard across all SUD services in California. One thing to note though, and this is an important parity requirement, full access utilizing that criteria of ASAM is not required for a beneficiary to start receiving services. That was an important critical piece. It's one of the changes that was made when the Parity Act for Medicaid came out, in where we had to ensure that someone had access to mental health or SUD services with no authorization for that initial assessment, to be able to be receiving treatment and to fully come into compliance. And that's true across our managed care plans, specialty mental health, and on our SUD side as well. So for example, those drug Medi-Cal services, all of those are available regardless of having any referral or authorization. You can get those. Once you get to the higher level acuity, just like in healthcare, you have to have more pieces on that front. Then to just note, the EPSDT mandate also applies on the SUD side for anyone under the age of 21. So broadly speaking, pretty comprehensive access to services needed for individuals under the age of 21. Next slide. So here, we've walked through the various partners and the split between the services, even how within, substance use disorder services, there can be a variance in regards to how it's currently provided in California. This is just to give a picture, of what the managed care plan. So if someone's in managed care or fee-for-service, they are responsible for that non-specialty mental health suite of services that I mentioned. You'll see on the slide the types of services that we're talking about: individual and group therapy, medication management services, psychiatric consultation, et cetera. Managed care plans are also responsible for some of the kind of primary care focused SUD preventive services, tobacco cessation, all of the screening, brief interventions, referral to treatment, et cetera, and some of the kind of primary care based opioid use disorder management. So there is this combination of where the managed care plans are overseeing a certain portion of those services and then handing off to our county partners. Another thing is our managed care plans oversee the larger prescription drug benefit today. As many people know, that will transition to DHCS in January of this year. However, would just flag here, there are certain drugs that are also today carved out to fee-for-service, even if you're in managed care. That would be all of your antipsychotic medications are carved out to fee-for-service, as well as some of your alcohol dependency drugs are also carved out. So just another dynamic in regards to that split. But all emergency room services, regardless of diagnosis, so that includes an emergency stay for mental health or SUD, is paid for by our managed care plans. That is not a responsibility of the counties to pay for those emergency room services. Now, while they may provide the crisis services, that is separate and apart from emergency room services. And then, of course, our managed care plans are responsible for transportation for all beneficiaries across all Medi-Cal services, including getting them transportation to specialty mental health or SUD services. So I just say this to paint the picture of the codependencies of these systems. One is responsible. So if you have someone going into a mental health into the emergency room with a serious mental health condition, the managed care plan is the one responsible for paying for that. They're going to know about it immediately. They'll see the authorization, but it's the counties who are ultimately responsible in the managed care plan to make those connections and that warm handoff to ensure that the follow-up is happening and that they are aware that that emergency department visit took place, that the primary diagnosis was either a mental health or SUD, and then connect them into that treatment. So it just allows for some constructs in regards to accountability and how those things are currently structured today in your conversations later. Next slide. So this is just a snapshot. So to kind of, we walk through what each is ultimately responsible for, but this also just outlines the differences that exist within the various systems. So currently we have our managed care plans, specialty mental health, and DMCDOs are considered managed care. While our at-risk plans, so our kind of bread and butter managed care plans who do medical and surgical, they're at risk. They have actuarially sound rates, they're paid a capitation rate, and they ultimately contract with providers to meet network adequacy and to provide these services. Some even subcontract, for example, for some of their behavioral health services out to a separate provider like Beacon. So you can see even within the responsibility within a managed care plan, you could have some separation between the prime plan, as we call it, and subdelegates. Then you have fee for service, which we don't need to get into much. But then on the county side, they are considered managed care, but they're paid cost-based reimbursement. Many of you are probably tracking. We're changing that in CalAIM in the future. They will have a different reimbursement structure. But on this side, it's different than on the managed care plan stand where they're contracting out. For both specialty mental health and SUD services, these services are often provided directly by the county themselves as a provider, or they contract out with providers, or they have a hybrid, right? So you can just see some of the various pieces in regards to the footprint and how it's different across the various delivery systems. One thing I would point out, and an important construct for people to understand, regardless of how complicated our system, federal parity requirements require to have consistency applied across all delivery systems, and that is across financial, what they call quantitative treatment limitations and non-quantitative treatment limitations. Essentially, what that means is access to care. The requirements for network adequacy have to be consistently applied across. The way you provide authorizations, whether it's in the managed care plan side or across specialty mental health and SUD, has to be consistent, credentialing, et cetera. So these functions, processes that impact someone's access to care need to broadly be applied consistently. And the state had to go through a lot of efforts back in 2016, 17, 18, and 19 to implement and come into compliance. We're still always looking at parity, and something to really make sure we're thinking about, because it also goes into the financial pieces of how you apply certain pieces across both physical health, mental health, and SUD services. Next slide. On this particular piece, it's just a reminder for people who may or may not know this, but we do have, in addition to those Medi-Cal behavioral health services, which is what I was explaining before, additional services that we provide, the Mental Health Services Act, or what's known as MHSA. We have mental health block grant, and we have what's called Sabji Dollars in the system. These dollars are really services that are otherwise not covered by Medicaid, Medicare, or private insurance is usually what these cover. They are typically going to be either an allocation base or a combination of allocation and or grants focused on certain initiatives. At the time, it can vary by county, but these are additional dollars being infused into the delivery system focused on things like community services, prevention, innovation, targeted things like first episode psychosis, et cetera, dollars that fund innovation and drive different pieces across the delivery system. Just something to make sure people are tracking. That's in addition to the Medi-Cal services. And this is where we spend a few $100 million annually funding these pieces across our behavioral health delivery system. Next slide. And this I won't get into too much detail, but just to inform the commission in regards to it, county behavioral health financing is complicated, to say the least. There was, through realignment, the responsibility to pay for community-based mental health services to indigent Californians was transformed from the state to the counties. There's both 1991 realignment, 2011 realignment, MHSA, et cetera. Essentially just, the funding of this through taxes and other kind of state and county relationships is just something to just be broadly aware of as you're talking through future state accountability structures, financing, et cetera. So hopefully that helped put some framing to the conversation today. Will, I'm going to turn it over to you so you can do a recap and or tee off some questions for the commission to dig into.
Great, thank you, JC. So what I was going to do at this point is certainly not recap JC's presentation, but rather sort of try to point to some areas that I think are going to have a lot of attention as we move forward in the thinking about a unified financing process as it relates to the behavioral health areas. As you've seen, sort of the publicly funded systems are supported by Medicaid. the Mental Health Services Act, behavioral health block grants, county realignment revenue, and now sort of not included in the fiscal chart that JC presented, but just approved in the recent budget, is a $2.5 billion infrastructure fund to sort of build out behavioral health infrastructure. And that funding is intended to go to counties and tribes primarily. What would be affected in a sort of a unified system? Well, if we think about it, counties have the responsibility under the Constitution for the provision of public health, mental health, substance use disorder, treatment, IMD, institutional services, and then very close ties to the county human services systems, particularly those programs that serve children and youth and the aged and disabled. So there is that very sort of close ownership at the county level and a sort of an assumption that the county has the responsibility to integrate these efforts and services. The second piece is when JC was referring to the tax and financing dimension. To support the county responsibility, the state has basically, as JC mentioned, in two events, 1991 realignment, which was during one extreme state budget crisis under Governor Wilson, and then 2011 realignment, which was the more recent budget crisis under Governor Brown. The state essentially created new revenue sources and directed them directly to the counties to operate a range of health and human services. In doing so, it's sort of, the revenue never comes to the state. It goes directly to the county, belongs to the counties. And this was codified constitutionally that they would sort of have this guarantee. A sort of a side piece of that, of course, is because the revenue does not come to the state, none of the state carve-outs of or sort of initiative-driven carve off the tops do not occur. So there's a sort of a complex fiscal dynamic sitting underneath there. MHSA likewise is sort of by public initiative and sort of constitutional. And so that any sort of movement of those resources has to be sort of put into that sort of context. It's not impossible to do. When ACA expansion occurred and the state through the Medicaid program assumed responsibility for indigent health care, there was sort of a very complex process, AB 85, that the legislators on the commission will remember, probably with some degree of pain, but it was a sort of a construction of moving revenue backwards and forwards between counties and state. But it was extremely complex and certainly is still regarded as an imperfect instrument. So as we consider a unified financing system, we have to account for who owns the revenue and then who is the presumed delivery system within that construction. Is it carved back into a unified system, therefore removing it from as a county responsibility? And does that have the policy goals and the social outcome goals that we would consider desirable? The disconnection of certain systems. Then, as we also, certainly from a DHCS perspective, think about moving to a unified financing system, a question arises as to how we sort of integrate that work and that thinking with the reforms that are currently underway that are not necessarily contradictory, but are not necessarily the same timetables or complete in terms of detail. So, for example, Mark mentioned as we were starting out, sort of the whole Cal-AIM initiative, which sort of is a very conscious and deliberate effort to say, how do we bring together physical health, behavioral health, social care to address the social determinants of health. In many ways, that may in fact represent the building blocks to a unified system. But again, so as we develop the recommendations from the Commission, it would be useful to sort of keep those initiatives in mind so that they're supportive. Those are the waivers that we are right now negotiating with the federal government. We're also at this point in sort of the parallel and very linked process of reprocuring all of the managed care plans. Currently, about 85% of the 14 million people covered in Medi-Cal are in managed care. Through Cal-AIM, that is projected to increase to 95% by 2027. The reprocurements that we're now doing for all of the commercial plans, and then those contracts will be sort of applied identically to the non-commercial plans, the COEs and local initiative plans. Those are to go live in 2024, with 5-year contracts anticipated. So again, there's just the issue of integrating planning in this process with that planning and timetable. So as the Commission starts to write our recommendations, our report, my hope is that these sort of questions and considerations will be among those, if not solved, at least sort of highlighted and teed up so that it's clear that in an implementation phase that these are questions that have to ultimately be addressed. So let me stop there, Mark, and see what the Commission is thinking.
Thanks, Will, and JC. Thanks for the run through and summarizing it and getting us a bit focused. As I've done before, we're going to take probably 35-40 minutes now to have a conversation about this. If we can wrap up a little sooner, I'll take it, but won't try for it. Want to make sure people have a chance to talk on it, but remember, this hopefully will come full circle and we'll be able to reconnect after Richard and Sarah have a chance to talk. I'm going to make some comments myself about some thoughts based on the presentation, but before, by way of teeing up some people to jump in next, Bob, I'm going to come to you to start off and just talk a little bit about accountable communities for health and how they might, in your view, serve a role on helping us achieve deeper integration of behavioral health in that more, in that different system of care down the road. And then, Anthony, I wanted to come to you afterwards just to talk about, as you've studied systems and thought about some of the attributes of those systems that have driven deeper failed integration or disintegration of care. What are those things that you'd like to see us change, right? I mean, if you had the wand, what might come together? But before those two jump in, and then I'll come to some others afterwards, I wanted to highlight, for me, I often think about systems and how they serve the individual that is, quote, hardest to serve or most complex. And I often start painting a pretty super sick, medically sick person in my patient who has complex medical needs. And then you get to the end of that thinking, and then you layer on severe and persistent mental illness. And that is kind of the really complicated patient that systems often either don't think to serve or really fail serving. And I think about where we are in California and where we are on behavioral health in particular. And without getting into, the deep different systems, county versus state, public versus private, which I think JC and Will did an elegant job teeing up. I'll just say we have a pretty diverse provider system. It's driven by a lot of different players who come in at very different times in the course of illness and in the course of time. They all get paid differently, right? So JC quickly ran through, we use fee for service, we use capitation, and we use cost-based reimbursement, even though we're moving away from cost-based in some areas, but we use all of that stuff. And it's complicated. And then, JC glossed over it, but we spend a lot of time talking about medical necessity. This term in behavioral health drives a lot of, it basically says what you can pay for and when you can pay for it for a certain patient. And the imprecise nature of that medical necessity definition is something that a system is going to have to grapple with. We're trying to grapple with it on a number of levels in Medicaid, and for kids different than adults. Kids in foster care different than kids generally. I mean, all of these different nuances on that point that I think is really important. And then the fact that we have a system more than on the physical health side that is frankly underinvested in, both on the sites where people can get care and the number of providers who are available to give care, right? We know that the length of time, the wait times for behavioral health services are longer than any of us want. And a lot of groups have a hard time meeting those timely access quote standards that we want to aspire to. So here's a system that I'm glad we take this issue on, because if we can really address how you, in a high integrity way, focused on the most complicated and the least among us of the patients, if you will, if we can figure that out, I feel like we can take on most any other issue. So I just want to open that up because I think this is really challenging on so many levels, and success of our system will never be what we wanted if we don't figure this out. And on the other hand, if we do, and we have a smart way to address it and build something that's really thoughtful for comprehensive behavioral health services along the life course for all populations in California, I think we will really be onto something. And then in a shameless reminder and plug for our children's behavioral health proposal that both the legislature and the governor and many of you supported, we're trying to do that for kids under 25 in California. The legislature, the governor in this budget put almost $4.5 billion towards this effort over 5 years with ongoing money after that, basically saying, we don't care who pays for your insurance. We don't care if you have insurance. We don't care where you get sort of connected. We're going to make a promise to all young people in California to try to be there for your behavioral health and wellness needs early, often. And if you need more complicated institutional care, we're going to try to get you connected to that. And that's a commitment we've made as a state. I like to think of it as our first sort of move in a unified financing sort of a direction. But it is also really trying to directly take on the issue that I think we're grappling with. So I want to start with you, Bob, and then I'll tee up some other people as well.
Yeah, thanks, Mark. I hope my reception is okay. If having a little bit of bandwidth issues, I'll go off video if I'm not heard well. Yeah, this has been a great tee up today. Hearing about centering of behavioral health and mental health issues in our state. And particularly, I think it's apropos, Mark, and thanks for your leadership in the behavioral health boost in the budget this coming year, particularly for our young people. But behavioral health is really a great way to usher in a conversation about health equity. Because it's beyond the four walls of the health delivery system. It just impacts so much of the adversely impacts the wellness of our communities. Let me just start a quick framing definition, how we at the California Endowment consider or define health equity. It's achieving the highest level of health for all people by improving the systems and conditions for all groups, especially those who have experienced racial and socioeconomic disadvantage or historical injustice. In this sense, health equity is advanced through the fight for social justice. And so we've got a long way to go to get to a unified financing mechanism that advances health equity. But we do have some experiences that were alluded to. I just want to lift them up in California to build from. We're gonna have to get bolder with our thinking and our sense of scale. But in order to address health equity, in consideration of behavioral health, the three things that our health system has never, that we've got to infuse and immerse a systems transformation approach about are three things: the matter of race, the matter of place, and the matter of power. And if you're not thinking about, if you're not centering race and place and power, we're just going to fall short on addressing these inequities. And so we know most of us are familiar with the history of racial injustice in this nation generally, but within the healthcare delivery system specifically. Place, both the experiential wisdom of grassroots leaders and groups and consumers, as well as the science and the data from NIH and CDC tell us that place matter. We know that zip code is a powerful predictor of life expectancy in this country. Whether you live in Florida, Kentucky, New York, or California, your zip code matters, place matters, and that's where the conditions come in. And then lastly, we've got to deal with the power dynamic so that, and many commissioners have spoken to this earlier, so that those that have been most adversely impacted by these systems figure into the accountability game. And I love the definition you teed up for us going forward. CalAIM, I just want to lift up CalAIM. Our efforts to modernize Medi-Cal is beginning to show how to build incentives into the true drivers of healthcare from an equity standpoint, and particularly from a behavioral health standpoint. And so, you know, whether it's the payment and payment requirement mechanisms to reach out to community and public health departments, providing for navigators and community health workers for affordable housing and transportation needs, incentives for healthy foods, programs sort of we funded called FreshWorks, which provided private sector capital into creating healthy food outlets in food desert communities. And then also we're beginning to see models around the country and also in California on the power and accountability aspect of accountable communities for health. States are beginning to integrate physical and behavioral health more effectively. Some of those states are Washington, Oregon, Colorado, and North Carolina. Rhode Island is experimenting with health equity zones. Our version of health equity zones in California are 13 accountable communities for health initiatives. We call them CACHI for short, California Accountable Communities for Health. Regional demonstrations, public-private partnerships, multi-sector collaboratives, where in places such as Long Beach and Imperial County, you're seeing public-private efforts to center the community experience in the delivery of healthcare through these partnerships and through these collaboratives, integrating behavioral health and physical health more effectively. Maybe in a future meeting, we can get a briefing from the Accountable Communities for Health effort here in California, just to begin to see how folks are beginning to experiment with these kinds of partnership models. And then lastly, making sure that we go beyond the typical advisory council of healthcare delivery and getting into what we started this conversation off with, Mark, the issue of accountability and governance, that those that are most severely impacted by behavioral health issues, by physical health issues, that those neighborhoods, those communities, those grassroots organizations are at the table holding the system accountable for racially equitable delivered care, where communities are centered and their experiences are centered not driven top down from health insurance companies and health plans, but from the grassroots experience up. And so making sure that those voices are involved and immersed into accountability and not just in some advisory function. I don't have a crisp, off-the-shelf, off-the-cuff answer about how to assure that a unified financing mechanism can address directly and clearly funding for these health equity needs for a racial equity approach and addressing the power dynamics. But I do know we have to figure it out. We have got to figure it out. And we don't have to start from zero. We've got some good things going on in this state. Some other states are experimenting with some very interesting models here. Again, a long way to go. But there's also promising, optimistic areas of partnership and activity that we can build from.
Thanks, Bob. I like the point you made early on about behavioral health ushering in a conversation on equity. And actually, I think it works the other way too. The equity conversation ushers in a really crisp conversation on behavioral health, because I think that often it's in those areas where the investments don't get made that people, communities continue to be behind, and we got to make those investments.
Exactly. And Mark, just one other point, which all the commissioners know this, but just to make the implied explicit, because we talk about cost, and sometimes we four-wall the cost issue around the health system. But if we have a transformed health system that centers the experience of the most impacted individuals and through a racial equity lens, and we're including behavioral health in that equation, you begin to decarcerate a very expensive prison system. Okay, we're spending $100, $125, $150,000 a year to incarcerate folks. You know, and we all know, the percentage of women in our prisons who are there as a result of trauma. We know what the science says about brain trauma and experiential trauma. Some of it racially injustice mediated, but in our jail systems generally, and particularly in women and in juvenile justice, you know what the impact of behavioral health is and how it shows up in our prison system and how we are treating far too many people with behavioral health issues in our prison system. So that's another place where enormous cost savings can be realized through behavioral health and an integrated system that works for people.
Yeah, Bob, thank you for lifting that up. I know in LA, we had that whole notion of care first and jail last concept, where so many people don't get that care, especially on behavioral health issues, before we start using the courts as our clinics, et cetera. So thanks for lifting up that important piece and the investments made in those systems that, frankly, could be used differently if we figure out where we're going to go. So Anthony, before you jump in, Dr. Pan, Richard, your hand's up. Thanks for having it up. I was going to go to you as well. I was going to, as you're thinking about the comments you wanted to make, also wanted you to, we've talked a little bit about CalAIM, both as a physician leader and a legislator, grappling with where we can go, and how does just thinking about CalAIM and some of the attributes of CalAIM that we're trying to build together, does this kind of unified financing system plus common benefits as an attribute, does that help us make progress in a way that maybe we haven't been able to through our typical conversations, typical levers, or do you feel like it doesn't change the equation too much? So I know you're going to make some other comments as well, but if you could focus on that. So with that, Anthony, take it away.
Thank you. And I first want to just underline what Dr. Ross said, because I thought it's just such I mean, I support all of what he said, but I want to underline the last part, which is just, again, this issue of costs and how much. I do think that while there's lots of reasons why healthcare costs more in America than in other countries, I do think I am persuaded by the work of the Commonwealth Fund and others that part of the reason is that other industrialized countries spend a lot more on the social safety net, and so our increased spend, and Dr. Ross highlighted on the justice system side, but I think it's true throughout the safety net, that the fact that we don't invest in a variety of areas, then it sort of comes out and metastasizes in the health side in terms of our costs. And so I do think that needs to be, I don't know how we include that in modeling and going forward, but it is something that is I think we should highlight. And so I am struck, and frankly, my comment I want to make into a question to Directors Lightbourne and Cooper, because there's some things that I think I'm pretty persuaded by, and that the evidence is pretty clear about, that how our system can be better. It needs to be universal. Everybody needs to be in. We need to center racial equity. We need to have behavioral health as something that we think about, from the get-go, and as a integrated part of all this, rather than as an afterthought. And all of those things need to be, part of it. I am struck, however, that that there are some issues where there is some tension between how much is this locally done versus at the state level. How much of this is, while we want things to be integrated, where are the decision points, and how do you prioritize in the best way? We've done a lot of work around mental health parity on the commercial side, which is, mind-numbing and really, really tough, because the commercial side doesn't actually have some of the same, as much as we spotlighted some issues on the public side. On the private side, it's even more fragmented, more problematic in terms of issues of access, issues of just even workforce and availability, issues of equity with regard to what the financial or other barriers are, et cetera. And so we can require the health plans to provide mental health parity, but what does that mean? And we're continuing to debate that and tease that out at the Department of Managed Healthcare and in legislation even this year. But I would say, but even on the public side, which is if single payer-ish in terms of it, it's fairly complex. And so then, and I would love to hear a little bit more about, to the extent that we have these various, bifurcations. I imagine some of these are for historical reasons, and historical reasons that we can move away from because of, it used to be that Medi-Cal program was a program for a certain set of people, various slices of people who met various specific eligibility requirements. And now in a world where, basically anybody under a certain poverty level is eligible. And I'm actually proud that California is moving ahead on removing the last big asterisk based on immigration status. But I think with that, we're doing that. And I think we did some of that through the most recent realignment. And I think CalAIM is a big part of sort of removing the vestiges of some of those historical reasons. Director Lightbourne talked about some of the reasons we did it, that they're based on funding streams, either county funding streams, federal funding streams, et cetera. But I also imagine that some of these bifurcations are because of just the tension of, okay, our current delivery system of mental health is largely based at the county level. So you have to sort of do it through the counties, and counties by definition vary significantly on their commitment and competence and capacity, in different ways. And, what's the tension between how much you want to centralize versus not, and also how much behavioral health should have its own focus with its own section or division versus how much you want to integrate it but then does it get lost in that section versus how much do you want to have its own center of gravity and own focus, but then it then becomes a part in its own silo. And I just love to hear from Director Lightborner Cooper about what is it that's historical and stuff that could be swept away that you're starting to do with CalAIM, and what is it that actually is necessary in order, because by the nature of actually getting the service to the patient at the end of the day.
Yeah, I mean, let me take a shot at that, Anthony. I mean, some of what has been historical and we can move away from, for example, the whole area of medical necessity in behavioral health. I mean, it has been implemented in at least 50 different ways across the state. And we're saying that's ridiculous. I mean, we have got to have standardized understandings of what is the access point for care, and then we have to standardize what is that quality of care, and that's an accountability structure that works in bidirectionally, to be honest. You know, Dr. Ross was sort of talking about community accountability structures, and that can't excuse the state from having its accountability structures. And without sort of wanting to create an image of, you know, the county being hammered between, you know, two forces. In truth, I think both of those have to be brought into play, and we have to have very clear standards. The second thing which we can move away from is this cost, you know, based reimbursement system, which does not incentivize the counties to really invest creatively. And so we are moving sort of through CalAIM into value-based payment systems for county behavioral health. Now, ultimately, that does leave a question: is it better to have this as a locally driven delivery system, or, you know, should we nationalize it or stateize it? I'm not sure there's necessarily a clean answer to that. The intervening questions that I think we got to put in the balance and be thinking about is, what other things outside of quote unquote health are intrinsically local that we need to keep a tight engagement with? Back to Dr. Ross's comment about incarceration and decarceration. Most of the incarcerated people in California aren't in state prisons, they're in county jails. If we're going to have a good behavioral health in reach for the justice system to start bringing people out of the jail environment and have effective reentry into the community, it has to be at least capable of working with the nuances of local decision makers around law enforcement issues. To the extent that we want to see sort of behavioral health sort of hardscape capacity developed and increased, one can argue that maybe the state should just do it all, but on the other hand, because of the locals' sort of control over land use and other issues, we will wind up necessarily with a balance. And as I said before, the social care institutions, the social determinants, are pretty much exclusively operated at a local level. Whether we're talking about, you know, the human service systems or housing support systems, those are all local. So as is public health. That's the other question. Can it be done either way? I'm sure it can. I think the bigger question, to where Mark and Bob were earlier, is creating the accountability structures that are effective and reasonable, but at the same time realize we're an awfully big state. And so let me stop there.
Thanks. I'm gonna keep us moving. Anthony, you use the one of the best strategies is ask the question right back at us. So appreciate keeping the conversation going that way. Dr. Pan, before you jump in, Carmen and Rupa, I'll come to you both in that order. And Rupa, for you in particular, wanted to just think about how in your comments, also thinking about, we sort of touched on behavioral health as an important piece, and actually it's connected to a lot more than just mental health or substance use disorder. It's connected to this fabric of communities. And what we have talked a lot about is whole person approaches to care. How does the unified financing system that you envision kind of address some of that, even bigger than just the behavioral health piece, which is daunting in and of itself, but I think we all know is either the tip of the spear or the iceberg, however you want to look at it. But Dr. Pan Richard, do you want to jump in next?
Sure. No, thank you so very much, Mark. And I really appreciate the presentation from both JC and Director Lightbourne. And I just want to keep in mind that the presentation they gave was actually, that's the unified financing, or I'm going to call it, that's the government financing piece of it. It's not actually the commercial piece in all its complexity and challenges. This is a particular area of interest of mine because that's part of the reason I ran for the legislature, is because as a developmental pediatrician, I take care of a lot of kids with behavioral health issues. And actually, interesting enough, I'm the one who takes care of the people sort of the in between. So yes, you have certainly people with tremendously complex medical and behavioral health issues, that they have a lot of challenges. But I also find that people who are sort of in between, right, who still may get mental health services, but also need it coordinated by a primary care physician. That's me. Developmental issues integrated with schools, challenges with school function, et cetera. And frankly, during the Great Recession, and I would point out that right now we're in a great budgetary situation. When you have a really bad budget and it's unified financing with government, I saw the consequences of what happened to those kids. And that's why I ran for office, frankly. Also, just as an Asian, I'd point out that, I appreciate what Bob Ross talked about in terms of racial equity. Not only do we have stigma issues, but we also have access issues, because mental health, if you don't have language access, mental health is really difficult, right? A lot of it's talking. So we have huge issues there in terms of access beyond just stigma and around mental health in the API community. I really appreciate what Anthony asked, because that's one of those tensions when we think about, because oftentimes when we talk about unified financing, we say unified financing, but the other question is what else is unified, right? And where's the direction coming from? And I think that's an accountability issue, right? So is it how much is local, how much is state, how much is federal? I would point out that local behavioral health, county behavioral health departments are still paying for a fine that the federal government imposed on them for not being accountable for their Medi-Cal money they spent, right? So we as a state, we helped finance that over several years. They're still paying for that. So that's accountability, right? They said they misused or they didn't appropriately use those Medi-Cal funds. And so they're still paying the fine for that CMS has clawed back. So there's an accountability piece. I do think that that as we're looking at, so I actually want to talk about two things. You mentioned, Mark, CalAIM, and then actually our $4 billion for children's behavioral health, which I of course fully support. Really appreciate the administration bringing forth. So, CalAIM, what we're trying to do is we're trying to figure out how to put these pieces together, right? Integrate it together. And frankly, what we're doing, and certainly, of course, Director Lightbourne and our Medicaid director, JC Cooper, correct me if I'm wrong, is that we're actually using our Medi-Cal managed care plans to help us do this integration, right? And that's what the procurement and so forth. And I know we have discussions here about the role of these intermediary organizations, but frankly, we're moving more people into managed care to better do this. We got to think about why. Right. So I assume that I don't think I have to just assume as someone who's been involved in the discussions is because we think we're going to get better outcomes. We need someone to be able to coordinate this. I guess we made a decision that instead of a state aid, instead of DHCS doing it directly themselves, we'd actually operate through the Medi-Cal managed care plans, because they're a little closer to the ground, some of them, because some of our county organized, other ones are, and they have the infrastructure for that, versus us trying to build that out on our own, right? And also, so how do we weave these things together, and also looking at the different parts that exist in law, and that in terms of who's responsible for what, right? So the counties have certain responsibilities, was described. The state has certain responsibilities. The federal government has certain responsibilities, and how do you line all those different things up together? And I think that's going back to what Anthony asked about, where's the, what level do you try to put this? I think that's a really important question. But actually, the larger sort of a related question that's a little larger is that if we create what's called unified financing, and we do quote unify the financing, so there's one body that's actually in charge of the money, then the question is that how much flexibility are we going to give people? Like, what are the rules we're going to set around it? How much flexibility are we going to give rules for those kind of innovations, right? That actually Dr. Rob Ross talked about, right? Because frankly, the bad news about all the different counties is that they're slightly different, and some don't do such a good job, or they don't have the infrastructure. The good news is that some do actually a really interesting job. They thought about it beyond what we probably could have come up with in the state. We have lots more people in the state, but because they know their local conditions too. And so, to what degree do we try to standardize things across the board, and what do we allow variation, which could be viewed? And by the way, I think one sensitive part about variation is that sometimes with variation, well, I say sometimes, oftentimes with variation, disadvantaged communities do sometimes get the short end of the stick, right? The people in power tend to have a bit of advantage. If you let them have variation, what degree do? But at the same time, if you try to stamp out the variation, you also lose the opportunity to innovate and come up with those different solutions. So, I would make that observation about if we're thinking about this, will we only talk financing? I think I heard no, we need to talk this larger system issue. Then how do we develop the system to create the flexibility? And I guess my final comment is that about the $4 billion for child health, which I'm very, enthusiastic about. But I would just sort of step back and let's just make an observation here. I think part of the reason we did this, now you can correct me if I'm wrong, Secretary Ghali, I think part of the reason we did this is to a certain extent, and don't forget, this is something proposed by the administration legislature. We're kind of in control of this whole thing that JC talked about, that Dr. Cooper talked about. At the same time, we said, what, for kids, we're trying to cut through a lot of this too, because we can't just take it and rework all these things, because it's so hard, because you have to negotiate with the counties, you got to negotiate this, take all of that. Let's just try to cut through some of this for the kids. We have this opportunity, EBSTD, and just try to build a new system, right? And so you can see even the people who are, quote, in charge sort of felt like we had to cut through some of the stuff that was presented, so we could try to hopefully build a better system for children. And then maybe from learning that, we'll then take it to adults or something. But I just an observation on my part, but I think that there's a little bit of that as to why we decided to do that with the $4 billion, because we were looking at going, okay, the schools have to do this, and the county have behavioral health like that, and we couldn't just make all the counties do this, with the schools, and make all the school districts do that. So and then of course you have commercial plans and so we're just going to cut through all of that and say, okay, we're going to put our money and we're going to build a system that way, through and so we don't have to go and anyway, you get the idea. So and by the way, this is all about this is all using, we're talking about at this point all the public dollars, right? We haven't even started talking about commercial. Yes, the $4 billion does address the commercial side, but so I think that's just part of the challenge, to think that just because you have, quote, unified or government financing, everything doesn't suddenly become really simple. You still have a lot of complexity, and we have to acknowledge that. And actually, some of it's for a good reason too. Some of it maybe not so good reason. I'm not saying we can't change some of that, but there's a reality to that too, that there are stakeholders, you have people who have vested interests, not necessarily for bad reasons, right? I mean, it's easy to say, oh, you're against me, you're bad, for oftentimes really good reasons, and then trying to figure out how to pull that together. So again, appreciate the conversation. Also, just want to mention, JC, I was going to be at Mental Health Caucus, but I'll be here, but I'm looking forward to hearing what you said for Mental Health Caucus. Thanks.
Thanks, and I'm gonna just not, even though I enjoy taking the bait that you just put out, I'm gonna leave it alone, because I want to make sure that Carmen and Rupa get some time, and if I'm lucky, before I'm gonna hold us to our time, give this about 15 more minutes before giving us a break and teeing up Richard and Sarah. Andy, I may come to you because I want to hear a little bit about what on the federal side, what your sort of sense is of where things could go to help in this conversation around behavioral health, and what the moves around parity in the recent years, decades, have helped us do things more locally with integrate both behavioral health and physical health, and bringing it together, and any cautions or advice moving forward. We can also try to address that in the back end if there's time to. So with that, Carmen, go for it.
Yeah, I want to kind of orient how we're talking about the issue a little bit here, because yes, there's a lot of fragmentation in the behavioral health system right now, in terms of which levels, county, state, it's run at. But I think when Anthony talked about the commercial plans, he's absolutely right. It's been abysmal in terms of mental health parity for in commercial plans, and we simply aren't getting it. If you don't have if you aren't eligible for Medi-Cal if you have an insurance plan, insurers often don't pay for behavioral health, or they don't pay enough. They don't appropriately value behavioral health and mental health care because it's not profitable for the insurance plan. So unless you can pay out of pocket, or unless you qualify for Medi-Cal, you often get nothing. So this is an issue of access that we haven't quite talked about yet here. And I think it's important to underscore that issue of this huge gap of people who don't have access to behavioral health care, because what we need to do is create and guarantee a right to behavioral health care. And that's the importance of having a unified financing single payer system, so that we have a single standard of care that everyone is guaranteed. We talk about medical necessity, the legal requirements for medical necessity in Medi-Cal, but we need to do that for everybody. And I think we have to remember that when we try to get rid of the fragmentation of the system overall, we can use those savings to expand benefits for everyone, and we can redirect the funds from the savings of eliminating the fragmentation to expanding benefits and to providing universal coverage. And then the other point that I wanted to raise here, which we haven't quite talked about, when Bob talked about centering racial equity, I really want us to dig deep in terms of what that actually means. And for me, that means that we do not have enough providers who are culturally competent. It's not about it's not about creating risk-based payments to make sure that the existing providers provide culturally competent care, because frankly, we just need to train more people and educate more people from the communities that don't have culturally competent mental health care to serve in those roles as licensed healthcare professionals. And I think when we go into a single payer system, a unified financing system, we'll be better to understand where the gaps are in mental health care, where their gaps are in culturally competent care. And we can say, hey, we will direct, we as a system, whether it's on the state level, whether it's on the local level, we will say, we need these types of culturally competent providers, and we will dedicate resources to train them and to get them into the system. And I think, overall, one of the big things that a lot of us know who are from Black and Brown communities, who are from these underserved communities, we know that one of the issues, particularly with behavioral health, is that we need to really restructure the way that we think about mental health and the clinical practice of mental health, because a lot of the times it's not appropriate. Talk therapy isn't necessarily appropriate for everybody. And it's very Eurocentric, and we all know this. And this is, by educating and opening up the streams for people who have the lived experiences from communities that don't have mental health care, we can try to start changing the very nature of the practice of mental health care in and of itself. And it's really, really important to try to get the white supremacy in healthcare professional education and clinical practice out. And we can't do that by, without getting these folks into the stream of the various professions, whether it's mental health care or other healthcare professions.
Carmen, thanks. I think, thank you for lifting up both points, both really important, and to just highlight the first one you made, something we talk a lot about in the Medicaid space, how certainly JC talked about this transition. Frankly, it's not one that we want or plan, right? If certain things happen in a more complete way in parts of the private system, the burden on the public system would be very different. And there's been a lot of conversation about that for years. It's a frustration at the local level. I think there's a lot of important conversations that have happened. And to your point, there could be some higher level structural changes to the way we finance and run healthcare that could take care of those issues. Rupa, you may or may not have the final word here, so go for it. And then if we can sneak in the question to Andy before we take a break, that would be terrific.
Thank you, and sorry everyone for being late. I was managing my children and technical stuff. I want to speak as a frontline physician. So I appreciate, Dr. Pan, that you work in a clinic. I've just got off several days taking care of Delta patients on high flow oxygen. I've been managing my own mental health this last year, the last 20 months being on the front line and watching people die from COVID, and watching community members unable to access care that they need. And watching, I just had dinner with a frontline nurse, an ICU nurse at UCSF who's been there for several years, who walked off the job along with 30% of the nurses in the ICU, because even in a nonprofit structure like UCSF, it's still still organized with a corporate mindset that has been defined by racial capitalism. And I just want to bring this up because thank you, Bob, for naming race, place, and power. Because our whole society here in California and the US at large has been organized through racial capitalism. I just released a 400-page book on this. I won't bore you with all the details, but I recommend it might be helpful for us to look at it or read it, parts of it, especially around the distribution of resources and power and how that impacts health broadly. So if you look at California right now, our state is on fire. We're in a probably what's going to be a multi-decade drought. We have energy issues to deal with and health. And these four things, our water, our soils, our lands, our health, and our energy, these are our commons. And these things have all been controlled by industries in California that have been unregulated, private industries that have derived a great deal of profit. And those costs have been externalized into the health of the public. The public health has suffered because of the food industry. The ag industry uses the most water in California, and we haven't rethought that at all. We haven't regulated it at all. We haven't changed what we're doing in the Central Valley as our state is on fire. And now the Klamath River, the salmon are dying. So all of these things are hopelessly interconnected. So we can't talk about one without talking about them all. And what we'll see now with the intersection between pandemic and wildfire, and now millions of kids around the country unvaccinated going back into schools, these things are intersecting in a way that we are grossly underprepared for. And any effort to try to ameliorate them through incremental change, to try to keep these private industries in place that have been profiting off the backs of providers and patients, is unconscionable right now. And I say this to you as a doctor who is so sick and tired of delivering health in the ways that we are on the front line. And again, Dr. Pan, I appreciate you're in the clinic. I'm watching people die. I'm helping them die. I'm helping them try to figure out how to, deal with their healthcare insurance company while their loved one is dying. I'm watching people not able to access healthcare. I haven't been able to access mental care. I have a great HMO, health net. I am a professor of medicine at UCSF at one of our best hospitals. And if I'm in crisis this last year, I had to call my HMO like 20 times. No one called me back, never got a provider through my insurance, had to pay $200 an hour out of pocket for a provider just to listen to me cry about how crappy our COVID response has been in California, like how Delta is surging, how people are unvaccinated. I appreciate that Blue Shield is vaccinating people. Did they reach all the people in, the backs of the restaurants while we were saying, let's take off our masks in the front of the restaurants? They didn't. That's racial capitalism. That's our brown and black people getting disproportionately affected and us not really integrating that into the systems of how we're approaching this pandemic. And so I just want to say that when we talk about behavioral health, that flexibility that Dr. Pan was talking about, that innovation that is hyper-localized, I'm putting that together with Bob's comments of letting those frontline communities lead, letting the nurses who walked off the ICU, let them lead the pandemic response. Do you think anyone would go without what they need? They wouldn't. Let the doctors and nurses and healthcare providers lead. Let the impacted communities who tell us exactly what they need for their mental health, let them lead. Let's get the private insurance out of California because it will constantly frustrate our advancement, not just in healthcare, but in agriculture, in our working lands. Our soils have been so destroyed, they can't sink carbon, they're leaching carbon into the atmosphere. We have to radically rethink these things. We have to radically rethink our water. And these things are interconnected because I'm seeing people now in the ER with, the lung issues from the wildfires. So I just bring this message from the front line to encourage us to not think incrementally. It's not time for that. That was like 20 years ago. We're at a time right now to think very bold. And I love the idea of eliminating the disparities between counties because those disparities have been created through race-based capitalism. That's why here in East Oakland, people have crappier life expectancy, 10 years less just down the street compared to up the hill. That is all because of race-based capitalism. And the way that we undo that is by changing the structures. And Bob, I'd be happy to come and give a talk about my book to the folks that you work with, anyone. I'd be happy to talk about my book to this commission because I think that these issues are so of the moment and that we need to be bold and imagine new economies that center care. And who better than our nurses than to lead that? And so I just want to uplift AB 1400 is sitting there in the California State Legislature. Let's bring that to the commission and look at it really carefully as a model and go from there. Carmen and her colleagues and Ash Kalra have already done that work. Why are I just beg you, please, just for.
So Rupa, I'm going to jump in on that one because I sort of have laid it out before and I'll do it again. Just a reminder, we're not going to kind of move on active legislation as part of the commission conversation. I think we're trying to cover a lot of what Carmen and colleagues have put in that specific bill and talk about them as components of this work. So sorry to interrupt, really want to keep us focused on where I think we've agreed to keep the movement going. I don't want to cut you off entirely. If you want to wrap up, please jump in.
Well, I would just say that I feel like that's an error, Mark, Secretary Galley, because I feel like the timing, the fires, the people in the ER, like, I just think it's a mistake. I think that we have something there that we should have a chance to sit together as a commission and say, do we want to look at that together? Do we want, it's there, it's active. I think we should have a chance to talk about whether or not we want to do that as a commission. Thank you.
Appreciate it. And as I've always said, we make decisions and we keep revisiting them. But I think there's a particular sensitivity around looking at wholesale legislation that's been put forward as part of this commission. So I think we have certainly tried to find ways to lift up elements of it, not it as an entire piece that the commission considers. So we will continue to do that, hopefully to strike the right balance so we don't neglect some of the really important aspects of that bill legislation as part of our moving forward. So it's 11:45 just afterwards. I want to make sure we take 10 minutes. So Andy, I might have you come back in the last hour because it might actually connect dots nicely as well. So let's come back in about 10 minutes. Let's stick to the agenda, 11:55. If we can start getting back on, and then we'll go into both Richard and Sarah's presentations. But thanks everyone for the lively discussion so far, and see you very soon.
Secretary Galley, this is just Karen Bloomer letting folks know that we are at the end of our break. Thank you.
Great. I was going to ask everyone to come on camera so we know you're back. If you're like me and you're holding food and you want to be off camera while you eat it, or on camera, no shame in eating, go for it. But I just want to see everybody's face for a second so we know we have everybody back. And we know you're going to jump off soon, so thanks for coming back for the presentation. I know Will was around. Wait to see if Jim. Okay, Karen, I think it's okay to get back started. You agree? Okay.
I do.
All right. Well, thanks. Hopefully everyone enjoyed a short break. So getting right back into it before I turn it over to Richard Scheffler and then Sarah, seamlessly asking them to do about 15 minutes each to tee up our conversation on sort of accountability. I think one thing I let everybody off the hook on, but I won't be as tolerant this time around, is really pressing on the question around, well, when we talk about accountability, of who and of what, right? So we didn't dig in as much on the behavioral health side on that question, and that's fine, but I think we do want to do that. But to begin, we asked Richard Scheffler to start us off, talking a little bit about integrated systems, how they use levers of accountability, risk-based capitation as well, and then moving to Sarah to talk generally about how we deliver on some of the access, quality, equity issues with using our accountability tools, and then really with a specific focus on thinking about some of the workforce and sort of distribution of resource opportunities to really drive towards equity and accountability. And then we'll come back and we should have a good hour plus to have more general commissioner conversation. And I'll especially give a chance to commissioners who didn't get to make some comments in the first half to have an opportunity to make comments in the second half. So yes, fair warning that if you jumped in on behavioral health, we'll sort of put you in the back of the line to make comments on this piece, just so we have everybody get a chance, but hopefully we'll have time for some people to make additional comments here as well. All right, so Richard Scheffler, Professor Scheffler, you ready to go?
I'm ready, Mark. I'm glad to be the lunchtime entertainment. Won't be as good as a 49ers game, but I'll do the best I can. So as Mark said, he asked me to talk about how integrated delivery systems can be used to promote access and quality and equity. And I plan to do that. Mark, in his wisdom, decided to tie one hand behind my back and asked me to do this without slides. So I'm going to be the only one that's actually going to pay attention to what you asked. And I'm not going to use any slides. This is a real challenge for me, but I'm going to give it a go. So the first question that you posed for us was, under unified financing, what dynamic would lead to improvements in equity, access, and quality? And you've already seen, and we've already experienced, that as soon as you talk about any issue here, the question of equity comes up. So I'm just going to briefly talk about that, because it's really impossible for me to make my comments about what an integrated delivery system would do on equity without some high-level comments about what equity actually is. I'm pleased that we're going to have a session at the end of September to do the real deep dive. So this is not meant to do that, but to just, as Mark likes to say, start the conversation going. And so when we think of an equitable healthcare system at a high level, what comes to mind? Well, it starts to me, as Mark introduced me as a professor, to start thinking about theories of social and distributive justice. This means that healthcare is distributed according to need and not based on a person's personal characteristics, economic or social position. That, I think, is the basic formation of health equity that's used in the NHS in Canada, NHS in the UK and Canada and other high-level income countries. But even with that, disparities, we know, still exist. This is not an easy problem. Funding is allocated in these systems on a calculation of need. This means that more resources often go to poor individuals and communities. So what is a health disparity? We use the term. So from my way of thinking about it, to use a metaphor, when we say there's a disparity, we generally mean we feel that it's unfair or unjust when quality care and health outcomes are due to issues related to race, culture, gender, sexual orientation, income level, social status, on and on and on. When they're related to that, we consider them to be unfair and unjust. And I think that's what we really mean by health equities. Disparities can be thought of in a metaphorical sense as a roll of the dice. When the dice are loaded in favor of one group, we consider this unfair and unjust. We need to remove all disparities to have an equitable healthcare system. What would that look like? For a healthcare system to be equitable, we would need it to eliminate disparities in access to quality care services, in the process used to deliver the care, and in the outcomes of care. For a more broader move towards health equity, we then are required to also deal with the social determinants of health. The social determinants of health include, but are not limited to, socioeconomic factors, physical environments, health behaviors, and things that Bob Ross mentioned related to your zip code, transportation, housing, income, the education, and food access. Under a unified financing system that uses risk-based capitation payments, we can adjust the payments for these key factors. Risk-based capitation will only need to occur at the organizational level to ensure there is a budget for populations, individual providers could still be paid on a fee-for-service basis. Because some people don't have a clear understanding of what we mean by integrated delivery systems, I thought I would just give you a broad definition about what we mean when we say an integrated delivery system. So it is, in comparison to the fragmented fee-for-service system, it's when all providers work together. When I mean all providers, I mean all doctors, nurses, physician assistants, pharmacists, frontline healthcare workers, all work together as a team. It's a team game in a coordinated fashion, and they share medical information. There's one patient record, and there's accountability and responsibility for the patient's outcome, and the resources used are coordinated. They all feel responsible. They are all accountable. And this means coordinated in inpatient care, outpatient care, pharmaceuticals, lab services, mental health services, on and on and on. So in sum, an integrated delivery system is a team game. It's coordinated and has one medical record, and it avoids a lot of duplication and produces savings in the healthcare system. California has the most integrated delivery system in the country. Over 65% of the providers are already in risk-based plans. Over half the doctors are in medical groups whose size is at least 30, and there are huge medical groups in California. Half of them are in medical groups of at least 30 or more physicians. We have already 80 ACOs, accountable care organizations. We already learned from the earlier session that the Medi-Cal program, which was already 70 to 80% capitation and managed care, is now going to be moving in the next several years to in the high 90s. And so this is all moving rapidly. At the federal level, we find in the Medicare program that most people now are choosing Medicare Advantage and moving away from traditional Medicare. It's around 40% in California. It'll soon be 50%, and it's moving rapidly. So this all leads me to the second question: what dynamics under a unified financing system will lead to improvements in health equities? Our ability to measure health disparities would improve dramatically if we could use one uniform data system. Individuals could be followed over their life course, and their equity could be traced throughout it. A unified system could cover everybody with the same benefits. Race, culture, gender, social, economic position would play no role, by making each patient equally valuable to providers. Personal characteristics would not be an advantage to one person over another. Eliminating the overly complicated, as we heard this morning, and incomprehensible paperwork to sign up for benefits and access to care would also be eliminated, and it would help improve disparities. Access would be improved for those who had limited resources as economic barriers are removed. If the system was financed by a progressive tax, it would improve the distribution of income and enhance equity, financial equity. So in the system of accountability, you imagine, which is the question I was asked, what would be done by whom if progress on goals of equity, access, and quality are not advancing as hoped for? To address this question, I imagine a unified financing system to have health plans and providers deliver high quality care in an integrated, coordinated system, which is patient-centered. At the highest level, the state would be accountable for health equity with input from all groups, especially those at the community level. Importantly, California's response to the pandemic and allocating resources at the local level did include measures of health disparities in its guidelines, as Mark knows, and he may wish to elaborate on how this was done. Given the racial and cultural diversity of California, eliminating disparities will be a real challenge. California is the wealthiest and most diverse state in the union, with the highest linguistic diversity, second highest in race and ethnic diversity, and the fourth most unequal distribution of income. This suggests that California both has enormous disparities as well as the resources to address them. Plans and providers need to be held accountable for health equity. A way of doing this might be the creation of a health equity score for plans and providers. Those with unacceptable scores would have their resources and payments reduced. The UK has recently created an observatory for race and health, which monitors health inequities and funds research to address them. France has done the same. Both focus on actionable policies that can be used to address health disparities. The Commission might consider recommending a similar monitoring and research approach, as well as recommending actionable items to unload the dice. Using health equity scores for integrated delivery systems, we can adjust their payments by the equity scores to address the social determinants of health. Thank you.
Richard, thanks for that tee up, and appreciate you going through slide lists through all of the areas. Really grateful for you doing it. I'll try to summarize some points after Sarah goes, and then we'll go into discussion. So Sarah, do you want to jump in, please?
Sure. Thank you, Secretary. And I will say this, the conversation today and the last couple of meetings have been very informative and moving. And I changed all of my notes. So please, Secretary, let me know if I'm droning on. I have no slides. Love not having slides. So I'm just going to jump in. And I was asked to address the same question as Professor Scheffler, starting with what dynamic will lead to improvements in equity, access, and quality, looking at how do we develop systems of accountability. And so I wanted to start by defining what we mean by those terms, at least what I think we mean by those terms, because it's hard to have accountability if people don't know what they're accountable for. And so in terms of access, I would say we want to have universal coverage, which means people are getting the care that they need when they need it without a financial burden in a way that improves health outcomes, improves their well-being. When we talk about quality, I would say that this is medically, culturally, linguistically appropriate care where there is not a misuse, an overuse, or under treatment that improves health outcomes. And then with equity, I wrote down exactly what Bob Ross said. Equity is really going to race, place, and power. And then what Professor Scheffler said, that it also involves social and distributive justice. That in terms of equity, it doesn't mean, it's not equality. It doesn't mean that we're looking at distributing our healthcare resources and care equally to everybody, but that there is a redistribution of these resources so that we're addressing the legacies of racism, of biases, of prejudice that is built into and has been built into the healthcare system and into our system. And then I would add in, as I always do, that we're going to need to talk about cost containment when we talk about any of these things and when we talk about accountability, because we need to be successful, we need a system that is both equitable and high quality, but is also sustainable. And having come out of the labor movement, I have said over and over again that every dollar that we spend in our healthcare system is a dollar that comes out of a worker's pocket. It's a dollar that comes out of a Californian's pocket. And under unified financing, it's going to be coming out of taxpayers or in the form of budget cuts. And we've gone through this before, and I think we just need to have cost containment and budget at the root of everything. So also, as we think about dynamics for improvement and set up accountability, I think a number of people have said that we need data, because we need to be able to set a baseline so we know what we're measuring and we can see change over time, and be able to identify who is where are the improvements happening and where do we need to see some changes. And so in terms of data, I think one of the advantages of unified financing is we can finally have a statewide unified look at our healthcare system. Where we have right now complete fragmentation, a real lack of transparency on prices, fragmentation of who has information because one purchaser has claims, and then we have Medi-Cal over here, and we have all these other systems. We can finally bring together a lot of this data and think about what data we have and what we need to collect in order to set up systems of accountability. You know, I know Secretary Galley and Dr. Wood did a lot of work on the Office of Healthcare Affordability, and looking at that proposal, it was a little bit shocking that we didn't have an entity that looked across the entire healthcare industry, from insurers, providers, hospitals, drug companies, to have one look. And that's what we need in terms of data. We have unified financing, we need to have unified data. And in order to get to equity, we need to collect information on race, gender identity, income, all of the data points on users of the system. We need to get down at looking at performance measures for health systems, for medical groups, and down to the very granular individual provider level, so that we can look at starting to do improvements if need be, or find models of like, hey, this is really working. We're really getting improvements in health outcomes. What are they doing at this level? And also an analysis of where are our resources? Where do we have medically underserved areas? Where do we have health systems and health facilities that have all of the most high-tech equipment, have the technology, have the providers? So do an inventory there, and an inventory of, as has been said before, where are the providers that are multilingual, that are culturally appropriate? Where do we not have those providers or a mismatch with the population? So setting up these systems so that we can really, in order to have accountability, we have actual things that we are measuring and we can measure change over time. Now for some of the levers of how we get there. I was going to talk a lot about payment and payment systems and payment reform, because clearly, you know, money in the system, money makes a big difference. And so payment is important in that way. I'm not going to get into that as much because the conversation triggered a lot of different ideas. But the idea of payment, I think, is really important, because that is one of the ways we can redistribute some of these resources. I do think that we need to look at other countries that have systems where they actually regulate prices. They regulate what people are paid. There's more of standardized pricing. That's also transparent. That's one of the things about Medicare, is that it is a publicly available, transparent system with a baseline that we can use to also build upon. And whether we're doing it as capitation or global budgets, or some system of payment, it needs to be where it's standardized and transparent. And then we can have a conversation about where do we need to have additional payments to achieve equity, to reward value and quality, or to increase access. So if we're talking about really needing to get more primary care physicians? Do we start having additional payments there? For providers that speak a number of different languages or come from the communities where they're going to be doing treatment? Do we use the payment system to try to encourage and create incentives to start moving resources where we need to have them so that we can address some of the health disparities, so we can achieve equity, and so we can really look at improving health outcomes? So payment as a whole, I feel like we almost should have an entire session on payment because there's so much there. And there's a lot of people on this call or on this meeting that know a lot more about it than I do. But it's a powerful tool. And so I think we need to use that as part of our accountability. And then just going to what Bob Ross said, which really, it stuck with me about race, place, and power, and the question of power that doesn't get talked about enough, but is critical to both access to getting quality and to be able to navigate the system, improve health outcomes, is we can really completely change to a single payer, to a unified financing system where everyone's covered. But we're going to still have inequities in people's ability to navigate that system, to advocate for themselves, to, be able to have the kind of coordination that they might need. And so I want to talk about what I think Professor Scheffler touched on, which is care coordination and how important that is. And I don't think that this needs to be done by insurers or health plans or managed care organizations. I really don't believe that we need to have financial risk-bearing intermediaries in this system. And I was even further convinced after reading the New York Times article about price transparency, where they looked at the 5 most powerful insurers and said, quote, that they got surprisingly unfavorable rates for consumers. And so at this point, you're like, what are they doing? What are insurers doing? They can't get us good prices and they're denying care. So is there a way that we can take some of the good roles, the managing care, and take it out of profit and have a new role? And so there could be a role for integrated health systems in care coordination. I think there could be a role for community-based organizations, unions, clinics, nonprofits in doing this kind of care coordination, either as a benefit under this new system, as a wraparound, as supplemental care. I think the model that I'm most familiar with, and I'm going to give a shout out now to the union I learned a lot about healthcare from, which is Unite Here. It's a union that represents hotel workers, so a lot of low income immigrant workers that you have low literacy, you have a number of different languages that are spoken. And they have across the country eliminated the middle people of insurers and health plans in some areas, or stepped in to do care coordination themselves and do care coordination in a way where they're helping to bridge the gap between the doctor's office and the provider and the workplace and the home. And I think unions are a good example, but not the only example of a trusted organization with access to workers or to patients that is not in the doctor's office and not in that context. You have union organizers that can go into workplaces. They can talk to people about wellness. They can look at, okay, who has a chronic illness and might need more assistance in either navigating the system or having adherence to protocols or to medication that who is low literacy that might need some of that help. And especially when we blow open and have no networks or completely open networks, there are going to be people that need that kind of navigator and guide, and maybe need it from someone who's there in other arenas of their lives that is trusted. And I think we see this with vaccines during the pandemic, that a trusted representative is someone that can cut through a lot of the noise and people will listen to. And this is something that could be formalized for a lot of different entities to have that role. And increase the roles in wellness and in making sure there's preventive care and in overall reducing the cost to the system. So in terms of, and I believe Carmen touched on this, and Dr. Ross as well, in terms of savings, outside of payment, there may be a need for just whoever is in governance of the unified financing system of having additional funds to meet our goals in terms of access, quality, and especially equity. And especially equity if we think of redistributing resources. And so I know that there have been proposals for health equity funds in the Department of Public Health, or racial justice funds within the Department of Public Health, where we think about what are some of the social determinants of health that really are standing in the way of us meeting our goals, and how do we get money outside of payments to get there. Looking at capital budgets or resources or technology. Where are some of the hospitals that, as someone said to me the other day, have koi ponds and marble lobbies? And maybe we need to figure out how to redistribute some of the resources they have to the hospitals that are lacking gauze bandages or PPE or other resources. So if we can't totally do it with a payment system, maybe there are funds that could be administered both through the governance of the system or in recommendations to the state and the people in charge that we need to really get this money out. And that's also something I think getting into what is going to be a huge workforce need, both of providers and then at all of the other levels, and making sure that we have a workforce that is linguistically and culturally appropriate in the places where we need them, whether it's rural areas or medically underserved areas. And I think I would recommend that everyone read Professor Shao's 2011 article on, I believe it was on the Vermont system, because there's some really great suggestions in there about how do you get medical students or healthcare workers to go to in other areas. Some of it was, are we going to do repay loans, but also home loans? Can we set up people in these communities? Do people want more days off, less administrative burden? Whatever it is, increased salary. Do they want to be salaried? How do we create these incentives to make sure that we have enough healthcare workers and needed workforce to staff the system, and that they are in the right places so that we're not just recreating the system that we have. And then in terms of accountability, which is one of my favorite subjects, although I like to think of it as enforcement. Besides having unified financing and unified data and health information technology, we need to have a unified or at least a collaborative regulatory regime. And part of that is going to be a governance question, which I'm going to leave to other sessions, because I know hopefully we'll have a robust discussion about that. But we do have a lot of regulatory and licensing entities in the state already. And there needs to be a lot of work together to make sure that we're able to hold the system, to people in the system accountable, because we are using taxpayer dollars to fund the system. And to the question of who's accountable, I would say the state is accountable, and the governing board of whoever is kind of making decisions about unified financing is accountable to the people who are paying into the system. But I will also say that any entity that is receiving money or payment or profit or revenue from the system should be accountable. We should just follow the dollars and say, if you are making any kind of money off the system, you have accountability to the system. And you should be able to know what you're accountable for. And this is going to require both, I think, the state level and then also delegation to local and regional offices. I think we have a great model with our local public health entities, with our counties who do a lot of this heavy lift. And we have other models through what I'm most familiar with, which is the Labor Commissioner and Labor Agency, where we have local offices that do enforcement, basically. And if you are not meeting the goals that are set out, like the secretary said, there needs to be consequences. And I think going back again to the Office of Healthcare Affordability, there were some good models built into that of what we say in unions of progressive discipline, right? Like if we identify, hey, there's an outlier here and they're not delivering medically appropriate or high quality care, or there's a system that's really failing on cost containment. Can we do a performance improvement plan? Can there be a part of the regulatory body that's saying, we want you to succeed in the system, we want better health outcomes, how do we come in there and help? And I know this is something that they've talked about in Massachusetts, with they have their kind of soft cap on growth. So a model there. And then if not, then thinking about what are the consequences? What levers does the state have in terms of, okay, well, just like if you have readmissions or hospital acquired infections, we're going to claw money back. You're not going to get paid for that. Or you're going to have some consequences because the state of California licenses you or has that kind of authority over your profession. And so I think we need to look at how do we then say there will be consequences for people who are not meeting the goals, or where there's cases of waste, fraud, and abuse, which is something that we are still going to have to deal with even in a unified financing system. And this, I think, is something that there needs to be a lot of coordination on the regional and local level with the state. And then just kind of along with that, I do think unified financing is just a good reform for the healthcare system, but I also think it's an incredible opportunity in terms of transformation societally, but also as an economic driver. Because if you look at the system, our workforce needs are going to skyrocket, and not just in frontline healthcare providers, but also in the number of people we're going to need in the public sector to be able to do the administration, the claims administration, the oversight, the regulatory authority. We're going to need more chief medical officers. We're going to need so many more people who are participating in the system. And that is somewhere where we can develop career ladders and start thinking about, we're going to create, the healthcare system is also an opportunity to create really good jobs for people to be a part of this. And so I don't think we have a session on workforce, but I do think that that is an incredibly important part, because it is very hard to distribute resources if we don't have enough people with the skills, both culturally, linguistically, technically, clinically, that we need. And so all of that is kind of built in and important. And so I'm going to conclude there and look forward to the discussion and all of our future sessions.
Great, thanks, Sarah, and thanks, Richard, to both of you for getting us going here, and appreciate both of you sort of taking head on who you think, where the accountability starts. You both said at multiple levels, but you both led with the state, assuming that the state is the one who's sort of coordinating and leading on the unified financing system. I think you described some other elements that I hope we'll get into the conversation. You didn't exclusively say it was the state. I think, Sarah, you said it. Richard, you alluded to physicians and systems, but Sarah, you said it. Anybody who receives funding from these dollars is to be held accountable. I think, I want to push a little bit on getting other people's view on the who and on the what of accountability. And I think there is, Sarah, you raised an important issue around cost. And how do we balance that accountability around cost as we're really looking at these important investments in other areas? And there certainly are systems where those go hand in hand, but one can easily see where they don't necessarily align. And I want to make sure that we get into that. Before we kind of open it up, and like I said, I want to ask commissioners who didn't have a chance to participate in today's discussion to jump in, but I did want to go to Jenny and Bill really quickly, because I think you both, Bill, regarding the Taiwanese system in particular, what's sort of the question around how is that system held accountable? Who's being held accountable and by whom? And what are the consequences when somebody isn't meeting the mark, if you will? And then Jenny, I wanted you in the PACE program in particular, as that important program that I certainly learn a lot from. Can you speak if there are lessons or concepts around accountability on how that evolved over time? Because I know it's a program that evolved over years and decades. So Bill, maybe I can start with you, Jenny, you, and then we'll open it up a little bit to broader conversation from other commissioners too. Bill, you're on mute still. Bill, we can't hear you yet. I think you're still on mute.
Okay. Now
there we go. Now you're on. Thank you.
Thank you. Thank you for the two excellent presentations. Lay out some of the issues and also the views by Richard Scheffler and Sarah Fox. To answer your question about Taiwan, actually that is something new. Taiwan's political leaders realize the health expenditure is going to be a major expenditure by the government. And the people who have to pay usually say, I don't want to pay more. And the people who want to get the benefits or get the payments say, I want more benefits and I want more payments. If the government gets into the middle, all the directions, pressures direct to the government. So the Taiwanese president actually called me in and says, I want you to design a system, take the government out the middle, because then it's just going to be political. So we designed it, and you can look in detail how that's designed. Basically, is you have a board that the payers are represented on it, beneficiaries are represented on it, and the providers are represented on it, and you negotiate. And then the government may set a maximum ceiling, say, the most increase could be XYZ next year, but it's just a broad guideline. This is how then produce a balance between the people who want more and also higher pay and the people who really have to pay, as well as insulate the politics, the special interest groups from it. I will strongly urge California think of that way. Think of an agency like Federal Reserve. You're still responsible to the legislature, as well as maybe to the governor, to part, but actually is semi-independent. You're accountable for the results. Federal Reserve is responsible on employment and the inflation rate. You hold that board, the agency then for the things you want them to be held accountable, and leave them alone, let them devise the best way to achieve it. So that's what I would share with you. And by the way, in my international work, most countries, the president or premier, when they heard that's the way Taiwan did, they usually applaud, say, yeah, I want to get out of that hot spot. Health is one of the most contagious and special interest pressure group. And the patients who have a disease always lobby, I am ill with this disease and I have this problem. And you have to solve it for me. So I would urge you to think of that way. I'd like to offer 2 comments beyond that about who, just commenting on what Sarah said. If you want to actually achieve the goals of equity, I think we all agree on equity is the primary goal, and that should be measured and that should be held accountable. The agency who runs it has to be accountable. Then the question is, who is below the government agency held accountable? And then a unified financing agency, in truth, the power you have is money power. And that goes back to what Sarah pointed out. Then you want to use the payment system, create the incentives down to the county level, down to the providers level, to focus on what patients need. So you have to dovetail, be patient-focused, but the delivery of care and quality of care, they are done by providers and managed maybe through the counties. In a large state like California, I believe that's going to be the case. So that goes back to Richard Scheffler's point. If you want to do that, you have to think about the financial constraints. How do you actually produce the efficiency out from the system, as well as improve the quality of care? That's integrate the delivery system. We can criticize managed care and so forth, but there are other ways to improve that on that. I will not throw the baby out with the bathwater, because you really need integrated delivery, just as was said in the behavior health in the last hour. How do we achieve that? Well, then my last point, which I'm going to say is, you usually achieve it by payment systems. For example, I would like to ask Richard and Sarah and anybody else, will you be in favor of this? Allocate the revenue of the unified financing to every county based on a risk-adjusted payment, but also taking into account equity. If they have lower income, you give them higher pay. If their mobility rate are poor, you say there's a greater need. That's what UK and Canada are doing. So we don't have to reinvent the wheel. You first allocate down to the local level, then let the local community manage that money. That's the allocation formula. And I would like to pose a question to Sarah and Richard is, do you think that has merit for the commission to think about? Thank you.
Thanks, Bill. On that, I think it's a really important and thoughtful question. Before either Sarah or Richard, or frankly, others jump in on it, Jenny, maybe you can jump in on PACE again, and then we can include, Bill, your question with the other questions that I think we have on the table. Jenny, go ahead.
Thank you very much. And what I'd like to be able to do is to address the theme of accountability, as well as Bill, your last question about, is there a way to have payment go to a responsible entity? And you were thinking county, perhaps. So what I offer is a bottoms up way of thinking about both accountability and payment. And that is, some of you have heard me allude to the PACE program, the program of all-inclusive care to elders. This is a fully risk-based capitated program that started actually in low-income communities. So it's a bottoms-up approach to it. So it started with a community of disparity. And so ironically, this was a program that was focused on well-being and clinical outcomes for people who would normally go to a nursing home. So it picks up, Mark, on your earlier comment of taking the most complex population. So typically people who reside in nursing homes have multiple conditions, including cognitive dementia issues, and have great functional and quality of living needs that are significant. So that's the care population I'm most familiar with and spent 25 years at. So let's jump to the integration. You have one entity, and it wasn't called managed care in those days, but the reality is that it's a capitated amount from Medi-Cal and a capitated amount from Medicare blended together, and the accountable entity is the program called PACE. And right now there are, I think, 20 different entities here in California. And I don't know the exact number since I've been away for 16 years, but it also operates in this format of accountability from the federal, the state, and the provider, the PACE provider. And so it's a contract that crosses all three entities. And so everything that's done for this population, and most people are eligible for both Medicare and in our state, Medi-Cal, we're responsible for everything. So it's basically, we are on the line, whether it's for payment, whether it's for quality, whether it's for ethics, whether it's for things like meals and transportation. And so it's a model that just takes care of a group of people who would normally be in a nursing home. And in the end, about maybe 10% end up residing in a nursing home, but they are still part of, quotes, our family. We are still accountable and responsible for their care. And it's a voluntary program that you come in and you have to qualify based on state criteria that you would be in a nursing home, but for being in this program. And so this is the model that comes about with accountability and financing and teams work. We have the majority of our staff are actually community-based health workers who are culturally from the respective communities, whether you speak Spanish, whether you speak Chinese or other languages, that there is a workforce that is matched to the population. And you have geriatricians to orthopedic surgeons who are part of it. We have a transport system. Basically, the goal is to be the accountable entity, and this predates accountable care organizations and the labels of such. But it's more person designed to help you live your best life, even though you are frail, may have dementia, and also supports the family caregivers if there are family caregivers, but is anchored on both the clinical quality standards that report up to all the licensing agencies. And then we have a community board that's part of the governance of these organizations. They historically have been not-for-profit organizations, but over the past probably 8 to 10 years, the for-profit entities have entered into it in a smaller way and abide by the same regulations, and they too become the accountable entities. So the long and the short of it, it's a system of care that follows you all the way from if you enter the hospital and come home, we're still it. So, you know, our efforts on the line. And the goal is to see that people get the care they need to live the life best. And the last point, during COVID, the death rate that we do know happened, you know, proportionally higher for older people was like 1/3 in the PACE programs throughout the country. It was far, far less. And so the ability to adapt to the needs of people were with them when they died, unlike oftentimes what we found in the main system, that people were able to convert things and do things to adapt to make sure that people's quality of life and their relationships to their families were honored during this time. So I just feel that this is one way of blending money, risk adjusted, as well as integrated team members and being legally and ethically accountable to a group of people who are extremely complex.
Thanks, Jenny. Exactly what I was hoping you would share, the bringing together of a number of things in one program that's actually evolved over a lot of time. Jim, Dr. Wood, can I pull you into the conversation as well? Just get your thoughts on sort of the broad ideas of accountability and some of the opportunities you see the state pursuing, others pursuing, or wherever you'd like to take it.
Great. Well, thank you, Dr. Gali, and I just want to put a huge exclamation point on what Jenny said. The PACE program, we have an active PACE program in one of the counties I represent. I wish we could expand this huge amount at a state level, because I think aside from the really important part about accountability here, it is also, I believe, a higher quality of care at a lower cost, more appropriate outcomes or better outcomes. And it's just a fabulous model. So thank you very much, Jenny, for that. I think that's an amazingly appropriate example of accountability and how things can work. And also it emphasizes the team approach and the integration of family and into this. And it's really a model that we should be looking at throughout the healthcare system, in my opinion. I want to, and first of all, I want to go back a little bit into what Sarah was talking about on data. And I think data is absolutely critical. We need information. We don't, we don't know what we don't know a lot of times, and there are a number of efforts that are in process looking at data. The all payer claims database will be up and running. Whether it's a state-run program or it's claims from insurance companies, we can learn about outcomes from how the money is being paid, how it's being spent, and from that information, we can demand accountability of providers and make sure that care is appropriate. The other component of that is we can also have a much better handle on costs and who is getting the best value for what they're doing. Why is it that in San Diego, people pay 20% less for their healthcare and get better healthcare than they do in far northeast California, a rural area? Why is that happening? Why are we not learning from that? So we absolutely, if we are going to be successful with a unified and fiscally responsible with a unified payment system, we absolutely have to get our arms around the cost and bending that cost curve. And it goes back to hearing from former Governor Shumlin, the challenges that they had, and we have to learn from those and those examples and people who have tried to do that. And so, and I know that Richard Scheffler is all about data. And I very much appreciate that about him and his ability to analyze. But I think we really have to look at, as we move forward with a unified publicly financed system, we need to be looking at some of these other things. We need to be looking at the impacts of consolidation. We need to make sure that data or health information is exchanged freely, so that as people travel and throughout the state or move between providers, that they get that information is timely and appropriate, that we're not duplicating services. And then finally, we need to get our arms around the cost. And so with all of that data, you can now force the accountability in many ways because you have examples of where it's going well and where it's not. And just want to come right back to the very end, or to the very beginning, and just put another exclamation point on what Jenny was talking about. The PACE system is a fabulous program. And if we could do more of those kinds of programs on the delivery of healthcare, we would all be in a much better place. Thank you.
Thanks, Jim. I want to, Peter, put you on the spot for a moment as somebody who's been running the exchange and working with plans on accountability. Maybe you can talk briefly about what has worked in that space, but then maybe what has been challenging about getting to accountability and accountability and transparency in some of the work that Covered California has done.
Thanks, Mark, and really great, rich discussion. Let me just first echo a couple of things. Sarah and Sarah Flock and Jim Wood's note on data and what we're holding folks to account for. And I just want to note that I echoing what a lot have said, I am sort of old school. I go back to the IOM and STEEP, which is safe, timely, effective, meaning it's got evidence behind it, efficient, you're looking at cost, equitable, core element, and patient-centered, which means culturally appropriate, et cetera. And we do that at Covered California through a whole range of ways that's anchored in data, including all of our plans give us all of their data. We slice it and dice it by race, ethnicity, other factors. The other thing that I'd note, though, and this is one of the challenging issues across the diverse views in this group, which is one of the things that's so healthy, is we've seen very variable quality of care amongst our 11 health plans and within our 11 health plans. So even Kaiser, which demonstrably far higher likelihood of getting good outcomes in Kaiser than in the other plans, but Kaiser has variation from health center to health center within Kaiser. But the points raised by a number of people about systemness, we actually hold our health plans to account for how they are promoting care coordination, integration, are they contracted with ACOs? And I would just raise this as an issue for the group to wrestle with is there needs to be an organizer. It doesn't have to be a health plan, but I don't want atomized 70,000 individual doctors pretending they're teams. And I think that Richard spoke to this, the issue of teamness, and as Jenny spoke to, it's coordinated around mental behavioral health issues, along with physical health, along with inpatient, along with outpatient. One person doesn't do that. And I do worry about a enforcement-y approach that looks individualized versus there will be intermediaries. We need to figure out, how do we classify them? How do we define them? And then how do we have the right data to assess what they're doing? And I'll note to Sarah, I love Unite Here, and I've met with them a number of times, but Unite Here doesn't employ the organizer of the care. They contract with, for instance, USC Medical School to be the care deliverer. So they've got an intermediary there, but they're the payer nonprofit saying, here's how we're going to structure our benefits so our people get the right time, and we're going to hold that intermediary accountable. So in some ways, to use the Unite Here metaphor, we want the state of California to be sitting like Unite Here does, not thinking about profit, thinking about holding the intermediaries they're contracting with to do the right thing at the right level. And that's what we try to do. And the challenges are data, one. The other bigger challenge that I'd note, Mark, and is we do a lot. We've got 1.6 million lives with us, 2.5 million if you look at the individual market, and we're tiny. The benefits of a unified anything is common signals around payment and around accountability. And my last note, I really want to applaud and appreciate Carmen's note, bringing us back. I'm sorry to jump to the prior discussion about behavioral health, is that, Mark, you set us up by saying, boy, the right North Star of behavioral health is those who are most in need. I agree and disagree, is 50% of Californians right now have employer-based coverage. If a unified system is getting rid of that, we sure better have a system that addresses those 50% of Californians' behavioral health issues. And for many of them, they aren't like the Medi-Cal mix. Medi-Cal is much more weighted towards people that are inpatient. They are more apt to be people we want to keep out of those settings. And Carmen's right, there aren't enough providers. So how are we changing payment so there's a stream of providers that are culturally sensitive? And if we aren't thinking through all of these discussions about what works for the 50% of the people that now have employer care, that under the vision of many goes away, this ain't going to work politically by a long shot. So we need to be looking at both. What is a system that works for people that have, quote unquote, day-to-day depression and anxiety, the big issues. And Rupa noted, she's not going inpatient, hallelujah, Rupa, but needed that therapy, that intervention of a person. And it is both the payers and the capacity that we got problem systems with, but we sure better be thinking about those as well as the Medi-Cal existing unified system we have now.
Thanks, Peter. And just to connect your point to the one Richard Pam made, which is, it's the in-betweens, the people who have some need, but in behavioral health, they don't have the sort of severe persistent need quite yet. And that connects back to one of Carmen's early points, which is some of the commercial, private, other carriers don't necessarily invest in that care, so that care dwindles and decompensates to the point where you suddenly find yourself in the Medicaid system, because that's the only system equipped. I can't tell you how often I've had friends or even patients with private insurance who envy what they get on the behavioral health side in the Medicaid system. And that, I think that ties home the point that Carmen made earlier. I want to make
very quickly to build on, sorry, you raised the question earlier about whole person care. Very often, unless in the commercial sector, there's mental health carve-outs, which I hate to love that concept, but you can't carve out from a human being mental health, behavioral health issues. And that's why you need an integrated system, which is looking at all of it, because that issue is a, if the finances are split up, you can't split a person up. And that issue about, a lot of discussions about how much are we holding to account the need for integration, because you can't separate out the behavioral and physical health issues because they're so related as well. So thanks.
Thanks. I want to give people, commissioners who haven't had a chance to jump in yet, to jump in. I see 3 hands up, and I want to make sure we get to you as well. But before I go to you, Carmen, I'm going to go to you first among those with hands up. Any takers from other folks? Okay. Carmen, go ahead, please.
Yeah, you know, I have a lot of thoughts on the discussion. You know, but to be a good student, I'll answer your question. You know, I think when we're talking about, you know, the accountability, it's the system and providers should be accountable to patients, and then the system and providers should be accountable for getting patients the health care that they need. You know, I think I want to caution us against saying that you know, that the accountability is to cost containment. Like cost containment is very dangerous in the sense that that could lead in towards placing that above our principles of equity, quality, access. And that shouldn't be the case. You know, we need to be able to figure out how we can meet those principles of equity, quality, and access without failing to get patients the care that they need. And I think, you know, the way that the governmental board and the regulators of the system becomes accountable is through the universal guarantees and the single standard of care that we create under the law itself. And I think, you know, all of this is really important because what it means is that to get to health equity, we need structural changes to the system. And you know, and of course, you know, I say this every meeting, this is why I think single payer is the way to do this. We have a single high quality standard of care. And I want to emphasize that, you know, if we have roles for intermediaries, gatekeepers, whether they're insurers or managed care organizations, what we're doing is building in fragmentation of care delivery and plans within the system. And this fragmentation, by their very design, will always result in unequal systems because there are different networks, different plans, and we can expect it to produce inequity. You know, and to go back to what Richard was saying earlier, and I want to make it clear from what I've said in past meetings, you know, I don't agree with the use of risk-based capitation or integrated payment schemes to get to health equity. I think these are inappropriate systems of accountability. And you know, to be clear, you know, we can't assume that integrated payment would result in integrated care. Those are separate things. You know, the payment systems, these types of risk-based payment systems, you know, they change the way that providers are basing their care decisions. They ask providers to be economic actors. And that's why I think that it's a poor system of accountability, because they're accountable, providers become accountable to their financial risks and their pocketbooks rather than accountable to their patients or their doctor-patient relationship. And I think, you know, as an alternative to say, you know, what else is there that we can have as a system of accountability? I do think, you know, in things like, you know, the single payer proposals that are out there, AB 1400, just to, you know, if people want to look more into it, we've created levers within the system to create systems of accountability so that we can regularly assess for equity, access, and quality. And the system, you know, a unified system is better situated to create the regulatory framework to implement interventions, structural interventions. You know, if we want to put it really bluntly, statewide health planning would be much, much easier and much more effective under a unified system with one plan, because there would only be one system and one set of rules. what we would do is first identify the health inequities and then direct the resources to begin the process of rebuilding our healthcare infrastructure. I think one of the things that in the bills that we built is, this regular auditing and assessment system, and we built in mechanisms to get funding out to different projects, whether it's creating more facilities, financing an individual facility for more staffing, for safer standards of care, safer staffing, safer health and safety policies within those systems. And I think this kind of direct provider to system relationship would make it easier for regulators to demand equity, quality, and access requirements in the conditions of participation with the providers. To answer Sarah's question, we can build in and we can demand with these direct negotiations with providers culturally appropriate care, safe staffing, good jobs, fair wages, so that it doesn't come out out of the pockets of workers. And I think that's why the single payer system with the direct payments model, when the system is directly negotiating with the providers, we can achieve that, because there is essentially an accountability structure in terms of the contract between the system and the providers, and we can manage that as a whole, because it would be transparent. One last thing that I want to mention is this idea, that we can fiddle with quality metrics or some sort of algorithm to assess health equity. And I want us to be very cautious here, because this over reliance on quality metrics and incentives and metrics that incentivize different types of payments in terms of quality or health equity, it turns into teaching to the test, and providers are less accountable to the individual patient's need. And we're really asking the providers again to profile individuals based on population statistics. And I think that really interferes with the doctor-patient relationship. And if we have a health equity score, it could potentially penalize providers with low scores because those providers care for sicker or historically underserved patients. I know there's risk adjustment, but risk adjustment has its problems. Non-medical indicators and other proxies can end up baking in racial biases, racial stereotypes, inequities in the provision of care. I think we need to be very cautious about these things, because we know, that there have been a lot of studies on how these kind of algorithmic risk adjustment tools can cause and exacerbate healthcare inequities. The problems of health inequity, it's based on social issues, and not medical issues. So we need to be very cautious about baking in these racial and other types of stereotypes when we're trying to address health inequity. I'll leave it there. I have lots to say. I know we're going to keep on going on with this discussion.
Thanks, Carmen, for touching on a lot of that. Richard, before you jump in, I want to just elevate a couple things that if people are inclined to talk about. I think, Sarah, you talked about the care coordination piece. Certainly in my clinical practice, like achieving care coordination and getting people, whether it was through people I worked with on the clinical team or community organizations and groups around to really help support that and facilitate that. I think connected to Bill's point about let's not throw it all out with the baby out with the bathwater, like that's a piece of this integrated delivery system, a principle that I think is really important, that the system we imagine needs to hold up and do. I can tell you in the Medicaid space, there's work through enhanced care management, a new set of benefits that we're trying to really build in care coordination, and it's not all on the backs of the providers, although it makes a lot of sense to be connected to primary care in those early early parts of the care delivery system. So thoughts on that? And then Bill, your question about the alternative that you threw out, Sarah and Richard in particular, if you wanted to jump in on that as well. But let's go first, Richard Pan.
Oh, thank you. This has been a fascinating discussion. Actually, I do have a question for actually Bill Schell, but maybe framing this larger issue, because he talked about this idea of, well, what happens if we gave a risk-adjusted amount, to counties, et cetera. And I guess the thing I would just, I always like to say, well, we can try to design the quote ideal system, but also we have to think about what some of the realities are. And actually, when I say look at I like to look at history. So, or other examples. So I guess the example I want to put out there is public education, public 8 through 12 education. The state, California, allocates money to school districts. School districts can raise some money on their own through their property taxes, et cetera. We try to, we believe in equity. We try to do it equitably. Admittedly, yes, we have people who don't like the existing structure, but they want to use public funds. Those are called charter schools. We have other people who walked away from the system. They still pay their taxes, but they buy private education. I believe there's no single payer system in the world which doesn't allow people, if they want, to basically buy out of it. I mean, perhaps a lot of people, only the few can actually afford it, but there are, people can buy out of it in Canada, UK, et cetera, or buy portions of it out of it if they wish. And I'm not sure we can constitutionally tell people they can't spend money on something they want. So can you perhaps leave this to Dr. Schell, but if other people want to weigh in a little bit on this, is that what can we learn from how we finance public education to looking at unified financing of healthcare?
Wow. I think that the attraction and of the unified financing is you have an equitable way to finance healthcare. Then you have to decide where you're going to have the next layer of administration that could be most effective. And so I was putting out suggestion, which that's what UK and Canadian central government has done, is they allocate their money to different regions according to risk-adjusted but equity-adjusted formula to say, we're going to compensate you because you've been shortchanged, because your health status shows worse. So there are underlying reasons for it. You need a resource to deal with that. Then you leave to the local community or the region to find their own answers. Then the central government, in this case, California government, will hold the counties accountable for it. And then you develop a monitoring system as well as some kind of you have to work out the kind of penalty system, which is unlike, I'm sure, or like the education system. However, from what I understand about the education system, you're giving a lot of independence to local school boards. I would argue you actually, the state, when you allocate the money to the county or region, you actually have much tighter rules, hold them accountable for outcomes. And if they did not meet those outcomes, you're going to penalize them or require them to change their administration. And that's where I think the difference are. And every county or region actually will go down to the next layer, maybe contracting out these accountable organizations, like we said, maybe a new form of integrated delivery system. If you want to integrate the delivery, as it's already said, you need an agent, you need an organization there to actually coordinate it and motivate the providers to coordinate with their colleagues, with nurses, with nurses' aides, with physicians' aides, with rehab centers. It's a complicated, what economists call a complicated production process. Somebody has to manage that. Regardless, you call them intermediary or managed care, but if you're going to have a coordinated production of the high quality care, you need an agency there. That agency, in my view, could be under the county. Let the county manage it locally. Just like the county school board may manage the school board, different districts differently in California. But I do think you want to remove the politics from this. Let me just tell you, I tumbled in American health policy for decades in Washington. I can tell you, I can show you my whip marks on my back. The amount of politics, the money politics that can influence and distort the system. You look at the distortions in Medicare, particularly Medicare, they come from lobbyists, powerful political groups. And I will urge this commission really to think hard, not thinking in very dreamy terms about the politics. You can let the government do it. Government is right now influenced by these powerful groups. As said earlier, how can we change that? Change the place, change the power. And we really need, as Bob Ross challenged us. So I think we should really think hard how to really think of different layers of administration, not just at the state level, then down to some regional level, then down to the providers level. Each one of that has who is responsible, what are they responsible for, and how do you create a power structure that they will serve the patient's interests, not somebody else's interests, like, let's say, health plans that are trying to make profits. That would be my long answer to you, Richard.
Thank you, and really appreciate it. I will point out, though, I haven't had a school board member tell me that the state didn't overregulate school districts. So even though you said they're fairly independent, everyone always says the layer above. Every county says the state imposes too much, et cetera. But I really appreciate your answer. Thank you.
Okay, Andy, see your hand up. Jump in, please.
Yeah, I'll be real fast. It makes me nervous to talk about a program where money gets devolved from the state to local or regional entities based on geographic characteristics. I don't think regions or localities get sick. I think people get sick, just to oversimplify. So where I'm going with this is back to PACE. As Jenny knows, I'm a huge fan of PACE. And the underlying driver of that arrangement is that individual Medicare beneficiaries, who also happen to be dually eligible as individual Medicaid beneficiaries, they have an individual entitlement to a defined set of benefits. And it's enforceable. And the funding streams get blended. the PACE providers accountable to the beneficiary, and accountable to both Medicare and Medicaid. I'm not arguing for a lot of different financing, but I'm just saying the point here is individuals have rights in the current system, and I would be very nervous about transferring those rights to localities or regions.
Thanks. I think helpful point on Bill's proposition around the county, and I think certainly counties are entrusted with a lot in California, and I think we think about the county structure in a very powerful way here, and I think it is different in different parts of the country, how counties are used and what's sort of divided between state and county responsibility. Okay, I don't see any hands up. Richard Scheffler, you're up, go for it. Richard, you're still on mute. If
Sorry about that.
No.
I think I heard more agreement than disagreement about the need to provide an integrated care delivery system. And it was just a difference in how one might do it. And my view of that is we all agree that it's higher quality care. All the studies that I reviewed are in the literature say so. It also happens to be more cost effective. So I don't want to scare people about what this means. I understand that people have this image of managed care, and I think it has a historical root in California, and the fear they have of it is really this concept of a gatekeeper. There's going to be someone in this organization who has the power to tell you, no, you can't get this care, and there's nothing you can do about it. I think there are a lot of managed care organizations that don't have gatekeepers. We don't use gatekeepers anymore. We use primary care doctors to coordinate the care. So I think that fear of the gatekeeper still has people concerned about integrated delivery system. I personally believe that it's impossible to have this team game without a team budget. The organization has to have a budget, and has to have some money, and you need to get that to them some way. And to unpack this and make this less complicated, if you were to distribute a budget, the first thing you'd ask is, how many people are in the plan, right? How many people in the plan? That's a capitation, because you get a certain amount of money per member per month. That's simply taking the number of people in the plan and paying for them. The risk adjustment part is simply to say people in plans have different health risks. This is not a complicated concept. There's no one who I think can on face argue that there's a problem giving a budget based on the number of people in the plan. In UC Berkeley, we get our budget by the number of students we have, undergraduate students, graduate students from the state, and we also get more money when they graduate if our graduation rates are high. This is a very common way of allocating resources. Now, there is a big difference about whether you go to Bill's idea of the county. And what I know about counties in California is you got Yolo County with 50,000 people, and as Mark knows, LA County with, I don't know, 8 or 10 million people. And so the capacity to do this in the 58 counties just varies dramatically. And there are rural counties and like, so I'm not totally sure that that's a good way to go. I would prefer to do it at the plan level. And not that the counties wouldn't have a role, but to give the money to the organization that delivers the care. And, as Carmen says, you can have direct contracting. I'm not opposed to that. You can talk directly to the providers and not have an insurer in the middle, but someone has to administer the thing. So if you don't have an insurer, the administration, if it's direct contracting, has to be administered by the state. Someone has to run the thing. So if you do direct contracting, someone still has to collect the money, the benefits, pay it out, and make sure that it operates in the world we have. So these are tough choices for the commission. I think there's lots of good evidence that California is a leader in capitated risk-based integration. The other thing I want to say about California is that money does matter, and we have an enormous amount of power in the money. I don't know what that is. Is that my phone? All right. So I want to point out to everybody, it's not only money that matters, but money is important. So I want to remind all the commissioners that the budget in California, if we had a single payer or unified financing system, will give whoever controls that budget more than 2% of the gross national product. That is, if you took the budget of California unified, it would amount to $2 out of every $100 spent in the entire economy of the country. That's how big and powerful that budget would be. And allocating that is important, but it's also extremely powerful in moving the system in the direction that you want it to move. It's a budget that's bigger than the total budget of 25 countries in the world, only have a bigger budget, total budget, than the healthcare budget would be in California under a unified financing system. So the money matters, it's important. We need to pay a lot of attention to how we do it. But I don't want to say that you can't have fee for service. There may be some possibility of that in some circumstances, but.
All right, Richard, thank you. And that's an important point. I think nobody disputes the role. And I think I heard it's money and it's the cost and some of these other things, which I think is going to be one of the good parts of us putting this all together. I want to, Antonia, want to call on you, and then my guess is we're going to have time maybe for one other comment, and then we're going to turn it back and do our public comment. But Antonia, please go ahead.
Well, first of all, I just want to compliment the presenters and the discussion. For someone who's not in the medical field, it is, I get it. It is so complex. And California is so huge. And we have so many different systems that it's hard to, break apart. So I just want to compliment everyone. This has been a wonderful educational opportunity for me. The one comment I do want to make was based on the recent comment about counties. I don't know medical, but I do know bureaucracies. And dealing with the county of Los Angeles is one heck of a bureaucracy. And if we're going, our goal is uniformity of quality of care, then we have to have a system that provides that uniformity. If you give that power to the counties, it's going to be county by county. So, from a practical structural perspective, we need to be mindful that we are trying to provide quality care to everyone in California. The second thing I would say is there's so much more in common. We all want the same thing. We want healthcare for all Californians, and I've been amazed at the fact that there's a lot of commonality. We all agree on the goal. What we're trying to find common ground is how do we get there? And so I hope we continue this discussion because I think, we're getting a sense of the complexity, the enormity of the task, and hopefully we can kind of focus on those common threads that when we put forth the report, it will be a roadmap for us to get to where we really want to go. Thanks, Mark, for giving me the opportunity to comment.
Antonia, thank you. I'm gonna actually use your comment to help us wrap up because I think it was a very appropriate one. That there is a lot in common. That there's, Richard, you said it as well. There's a lot of agreement, even more than some of the disagreement. But that disagreement is important, and I think something that we're gonna continue to flesh out. It was a wide-ranging conversation, so I'm going to spare myself and all of you of my attempt to summarize it. But in a couple of points, I think the behavioral health discussion, I think, underscores that California, because of our unique nature, is going to have to consider some parts of the delivery system in its unique ways, but that we also run the risk of overcomplicating it, and some of the benefits of the unification of the financing provide some opportunities potentially to do some things in the behavioral health space, in the public health space, in certain other areas, the social care space, as I know we like to talk about within Health and Human Services Agency, that we may not be able to do in a financing system that remains fragmented. So I think there's an opportunity to think through that a little bit more in our comments in the final report. And then in this second part of the conversation around the focus on accountability, I think the one unifying theme, I think, is that unified financing drives a few opportunities around accountability around data, accountability around a standard approach and a standard set of benefits, and then some real opportunity around how we think about the distribution of resources, whether it's the financing or the staff, and those go hand in hand in that equitable way that I think Bob, Ross, and others, Richard, Sarah, I think you all lifted up a definition around equity that really highlights the fact that with our resources, whatever form they take, there's an opportunity to overinvest to allow some communities, some populations, some people to catch up, if you will, and raise those boats more than some others that are already higher. So I think there is, Antonia, you said it, a lot of, I think, common ground here, and I'm looking forward to trying to put it together in our summaries and those goals and priorities that you'll be getting as commissioners in the days to come to review, to add, to make sure that directionally we're going in the right direction so that we can really kind of benefit that final report that I know is on everybody's mind. So with that, I didn't shortchange public comment too much. Karen, I'm going to turn it back to you. I see a number of hands up, and I appreciate as many commissioners that can stay to listen in. Please do.
Thank you, Secretary Galley. We're now going to invite public comment until just before 2 p.m. Pacific time. So we'll be opening up the chat feature for those who would like to provide written comment that way. Again, there's still the email address you can use as well. We'll be calling on folks who would like to make a public comment verbally one at a time. When I call your name, you'll see a button that invites you to unmute. You're also welcome to turn on your camera at that time. We'll be taking just 60 seconds of comment per person to allow for as many members of the public to speak as possible. Please do state your full name and any organizational affiliation when I invite you to speak. All right, with that, I'm going to invite William Bronston to go ahead.
Thank you, Karen. I'm a physician, and I'd like to speak to the larger question here that Carmen and Rupa have spoken to, and Bill Tsao. First of all, the public health system, there are 61 counties essentially in the state of California, and underneath them are organized neighborhoods. The democratic foundation for the assessment, evaluation, and priority setting needs to come from a formal inclusion of those neighborhood networks in every county that work in close tie with the local public health department. The public health system has been bled of resources since the 1980s and needs to be doubled in size. Global budgeting needs to be provided to all health science public post-secondary schools in order to fundamentally fund, with no education debt, a new workforce in the state of California that will address Bob Ross's concerns for altering the caste, class, race, and linguistic capability, the cultural competency of all of those workers. I believe that there needs to be a profound decentralization in the system, which means that there has to be local decision-making and local priority setting. And I believe that the single payer system will change society. It is a social paradigmatic, fundamental foundational change that will alter society and the democracy.
Thank you. Please remember just to hold your comments for 60 seconds. We have many people who would like to speak.
Sorry.
Thank you. Bruce McLean, you're invited to unmute.
Hi, I'm Bruce McLean. I'm a member of the Butte County Healthcare Coalition, a CARA member, and a member of Healthy California Now. I would like to recommend to the commissioners to see the film Power to Heal. It's a documentary film which really demonstrates the power of the purse and how the intersection between the civil rights movement and Medicare led to the beginning of the integration of our hospitals and healthcare system. This film's about an hour long, and it is very good in pointing out how the federal administration used the threat of non-payment to force desired behavior, and that was integrating healthcare facilities. Thank you.
Thank you so much. Peter Shapiro, we invite you to unmute.
Okay, can you hear me? Yeah, my name is Peter.
Oh, Peter, you just went muted again. Try again. There you go.
Okay, sorry about that. I'm a delegate from the California Alliance for Retired Americans to the Alameda Labor Council and a board member of Healthy California Now. I am dubious about the claim that the high cost of healthcare is due to providers who are incentivized by fee-for-service to overtreat patients. All the indicators from infant and maternal mortality to life expectancy suggest that people in this country get too little treatment and not too much. The problem is we pay way too much for the treatment we get. And I have to respectfully disagree with Dr. Scheffler. There have been a number of studies of Medicare's attempt to use accountable care organizations to reduce costs, and they've all reached the same conclusion. It doesn't really work. I'd refer you to the August 23rd issue of the Journal for General Internal Medicine for a summary of those studies. Personally, I do not care how providers are compensated, whether it's by fee-for-service or capitation or whatever. I'm inclined to think the entire issue is something of a red herring because healthcare is a seller's market.
Thank you, Mr.
And as long as market forces determine how it's delivered, costs are going to keep rising and serious inequities will persist. If you have a fragmented risk pool, profit-making entities are incentivized to avoid risk. Some of us are always going to get the short end of the stick, usually the most vulnerable among us. Now, I have a advisor help. Am I done?
So sorry, Mr. Shapiro. We need to move on to Michael Lighty. You're invited to unmute.
Thank you, Karen. My name is Michael Lighty, president of Healthy California Now. Really appreciate Dr. Shao calling out the role of the healthcare industry because I don't think it gets enough mention in our discussions. Medi-Cal managed care has diverted billions of dollars in profits away from care. The plans on Covered California are ultimately accountable either to their shareholders, in the case of for-profits, or to the board of directors who allocate the net income for capital expansion. In the case of Covered California, my own experience is that I am switching coverage because I lost my COBRA plan, can't find a single plan on Covered California that gives me access to the same specialists that have been treating my disease. I think it's vitally important that we understand that we cannot have financial incentives under any system, be it fee-for-service or capitation, that diverts resources from patient care. And finally, it's vitally important to understand that if we're talking about hundreds of billions of dollars in savings under a single payer system, as the consultant report pointed out, those savings can go precisely to the interventions that are the social determinants of health. That is a key point.
Thank you. Bill Honigman, we invite you to unmute.
Thank you. Can you hear me?
Yes, sir.
Thank you, commissioners, fellow advocates. I'd like to add my testimony to the subject of accountability. As an emergency medicine physician for over 37 years here in California, I saw many patients who failed under our ridiculously complex multi-payer system. This was especially true for those with untreated or inadequately treated behavioral health issues, and often among our BIPOC communities and our unhoused populations. We're seeing this today play out right now in front of us in an exaggerated fashion with the crisis of COVID-19, as Dr. Maria says. The first and most important pathway to eliminating those barriers to equity and access in care is to eliminate the multitude of commercial proprietary interests with a single standardized, transparent financing system, such as is currently before the legislature in AB 1400. So please repurpose your goals commission model AB 1400 and advise the governor to move it toward passage. Thank you very much.
Ryan Skolnick, we invite you to go ahead.
Hello there, my name is Ryan Skolnick, and I want to address the refusal of this commission to discuss AB 1400 because there are a few deeply troubling things going on here. First of which being that this process is unacceptably secretive. Secretary Galley earlier today said there was, quote, sensitivity to whole-scale legislation being discussed. And I want to know who exactly is sensitive to discussing a model of financing already under active consideration. Was this a unilateral decision, or has he received feedback behind closed doors? This is why questions of process should be transparent and discussed in public. Second, this commission spent enough time discussing issues with our healthcare system. We all know them at this point. The commission needs to start discussing concrete policy, and the commission is statutorily obligated to address single payer in its final report. Ignoring a complete single payer model under active consideration is policy malfeasance, and it makes a mockery of the process. If commissioners have objections to AB 1400's model, they should be openly discussed, not bottled up by shadowy process. Get to work and stop ignoring AB 1400.
Thank you. CT Weber, we invite you to unmute.
Yes, my name is C.T. Weber. I'm the legislative liaison for Peace and Freedom Party of California. I think this is a main thing we need to talk about is the costs. And I think if people look at the costs, they'll see that probably about 25 to 35% of the cost of medical care in California, the country, is basically administrative costs due to the many insurance companies and debt collectors that they have to pay, and also to the profit system itself. Once those are removed from the system, you got another 25% that you can add to our system to help pay for costs. The rest of the money can come from the normal sources where they're coming from now. And between those two sources, where the money's coming from now and the savings that we get from the profit and the administrative costs, we're going to have enough money to fund the system. So I think that this commission ought to, as other people have said, look at AB 1400, check out the analysis on the various savings and the costs, and put those into writing so that we can all have something to work with. Thank you.
Sean, Sean Broadbent, please go ahead.
Yeah, hi, my name is Sean B. From the Democratic Socialists of America, Los Angeles Healthcare Justice Committee. As a report from the New York Times this Sunday showed, insurers do not add value in our system of care, but rather seek to extract the maximum amount of profit from it. A long fought for price transparency rule showed random variances in the cost of procedures within hospitals from different insurers. That is to say, they extract profit wherever and whenever they can. We're all the worse for it. This profit seeking has met its limits as millions now delay or go without care completely rather than pay the ever-increasing copays, cost sharing, and deductibles that accommodate insurers' greed. California is sicker and poorer because of this. While we may have the choice to temporarily delay our care, eventually the bill comes due in the form of ill health, and too few of us have the guarantee of receiving care once we need it. A moral, rational system of care is possible under CalCare AB 1400. Instead of pondering different design considerations that AB 1400 already addresses, this commission should focus on studying and proposing different methods of financing for the remaining costs of single payer that can't be recouped with federal dollars. Thank you.
Thank you. Ruth Carter, please go ahead.
Thank you, commissioners, for the work that you've put in so far. I'm the chair of the California Democratic Party Senior Caucus, and I'd like to speak a little bit about Medicare Advantage, which has been touted as being the answer. However, up front, it appears that its plans offer a better financial deal to seniors than traditional Medicare does, but the reality is quite different. The June Kaiser Family Foundation report found that over half of Medicare Advantage enrollees would pay more than their traditional Medicare counterparts for a 6-day hospital stay. Additionally, the federal government is seeing large year after year increases in the amount paid to Medicare Advantage providers. Insurance companies have nearly doubled the margins in individual and group markets for Medicare Advantage plan. Furthermore, a June 2021 Government Accountability Office report found that MA beneficiaries in the last year of life disproportionately disenrolled to join traditional Medicare because of issues with their care. The California Democratic Party is on board with a single payer system, and I urge you to look at the AB 1400. Thank you.
Linda Chapman, please go ahead.
I'm astonished to hear people believe that Medicare is transparent with regard to funding. Since I worked for the administration, we were taught exactly the opposite. And even, my friend Betty Bernstein, who was the voice of Social Security more recently in San Francisco, the same thing. Doctors mine it, traditional Medicare, people who want to get rich. The only safe thing is to have managed care plans. I got into Kaiser not because of Medicare when I was very young, because my body was being treated as, the way to get rich with all kinds of, we were going to go do surgery. We did vast numbers of medical tests and x-rays and all of this. And when I went to Kaiser, they said, drink more water. That took care of it. I have just known terrible conditions that happened to people because Medicare was paying, people who were, my friend who was in the hospital for $450,000 worth of mental health treatment, kept there against her will when she didn't need anything. My uncle, who died slowly because Sutter would not let him die, they fought massive infections and so on because Medicare was paying for it.
Thank you,
300.
Sorry, thank you very much. Daniel Lee, please go ahead.
Hi, my name is Dr. Daniel Lee. I'm also vice mayor here in Culver City in West LA. Wanted to talk a little bit about not just integrated cost, but integrated service and the need to create a platform for data sharing or an API that would allow customer data to be shared across the continuum of care. I think that's a necessary intermediary step between what we have now and a single payer system. In the context of single payer, I think there should be more specific discussion around AB 1400. And if the commissioners do not agree that AB 1400 is the way to go, then there should be a particular suggestion of a different type of single payer system based on some that already exist in Asia, the UK, and other places, so that we can get to the type of care that I feel like we've been talking about really sort of theoretically, really get to some practical considerations. Thank you.
Thank you, Doctor. Thank you. Christian Shaughnessy, excuse me, please go ahead.
All right, good afternoon, sisters and brothers. My name is Christian Shaughnessy. I'm a community organizer with SPX Youth and Family Services, and I have come here today to testify to the immense importance of a single payer healthcare system. At the current moment in the United States, the human being is not respected. We are treated very much as a commodity, like any sort of basic good that's traded on the marketplace, and the human being is not seen as worth something. And we can see that in the way that one has to endure thousands, if not more, dollars of medical debt in order to save lives. Oftentimes, we see many a time that taking an Uber to an emergency room is actually cheaper than taking an ambulance. And from my own personal experience, there have been times where there was a time in my life where I wanted to take my own life. And then as a result of me actually going to the emergency room, as the result of me actually wanting to get treatment, I had to pay $5,000 of medical debt. I had to endure that. That is a heinous and wicked system. The fact that that takes place in a country that has nearly $1 trillion military budget is despicable, and we absolutely need a better society. Thank you so much, Karen. And
Thank you. Bryn O'Neill, please go ahead.
Hi, Bryn O'Neill. Our accountability system needs to be charged with ensuring that all Californians can get culturally and linguistically competent care, like the CalCare Board mandate under AB 1400. CalCare would be responsible for ensuring that healthcare professionals receive the necessary education and training to increase delivery of culturally competent care for underserved communities. Importantly, funding could be directed to increase the number of doctors, nurses, and healthcare workers from underserved communities who come in with those diverse cultural and linguistic competencies. We also need to prioritize projects on health equity and ensure that there are dedicated funding mechanisms for projects that would improve healthcare services and address inequities. And we must structure our payment system to ensure that healthcare workers are fairly paid, fully resourced, and have the tools and time they need to provide that culturally competent care. Thank you.
Thank you very much. Corinne Frugoni, please go ahead.
Thank you very much. I'm a member of Physicians for a National Health Program and Healthcare for All. And I'm a family physician. I want to tell a story about a patient that I saw once a number of years ago who had been a member of a vast nonprofit, actually a single payer system in the United States that used accountability and transferred it to the individual providers. He came to see me because he said that when he was seen at this other organization, because he had diabetes, that is all the providers actually focused on, because that is where they either got incentives to get paid more or got punished if they didn't get the certain quality metrics. Why did he come to see me? Because he was coughing up blood, and that was never addressed. So we have to be very careful whether it's profit or nonprofit when you start talking about accountability and what you are trying to create accountability for. We also forget that under a single payer system, patients will contribute to the quality of care because they will have a choice of where they go. Now, sometimes patients don't make good decisions. Sometimes they make much better decisions, but they will have a big voice. And lastly, the bill, as a friend of mine said, the bill that cannot be mentioned, AB 1400, please look at it. I haven't heard many original thoughts during this entire meeting because they're all included in AB 1400. Thank you.
Stephen Martin, please go ahead.
Can you hear me?
Yes.
Hi, thank you so much. Hi, everybody. My name is Stephen Martin. I'm a community organizer, and that is because the Affordable Care Act saved my life. When we're talking about finance mechanisms today, I would hope that some of the data that we would consider when designing the finance system for this healthcare plan, that we also include sexual orientation and gender identity data inside this analysis, as some of our community members need more culturally competent care. And we need to find a way to pay for that on the front end before we have to go and fix it on the back end. The only other thing I would say is that if we are going to delegate powers to the counties, I would just hope that we would be very careful with payment mobility. So when I worked on a congressional campaign, I held healthcare town halls, and one of the biggest things I heard in the high desert was their inability to access care, and that they would have to drive all the way into Los Angeles to get the kind of care that they need. That creates an interesting payment conundrum around counties. So thank you very much.
Thank you, Mr. Martin. I can take this last speaker, and so if you did want to provide some comment, please feel free to use the chat at this time. I'm going to take Michelle Grisat. Please go ahead.
Michelle Grissat, Director of Health Policy, National Nurses United. The first issue in integrating behavioral health is addressing California's hundreds of mental health professional shortage areas. A single payer system can prioritize funding underserved areas, including funding education for members of underserved communities, so everyone has a licensed provider who understands them. Many health professionals now accept only private pay clients, largely because of poor payment by health insurers. Single payer will ensure that mental health professionals are paid fairly and guarantee mental health care to all. It will eliminate the access and quality gap between patients who can afford to pay out of pocket and those who get tightly limited services through insurance. Thanks.
Thank you. Secretary Galley, I'll turn back to you now.
Appreciate all of the public comment and those comments in the chat. I have a chance to keep reading through them as we go along into the commissioners. Thanks for participating in the conversation. We will be coming out. We're going to rejigger. Just wanted to make sure we're looking at restructuring a bit of the roadmap that we came out with and move the payment conversation and the federal engagement conversation, flip those a bit. So moving up the federal engagement conversation, I'll be reaching out to a couple of commissioners to see if you can help me tee up that conversation soon, and that will be what we focus on in September. And then looking to focus on the payment conversation that Sarah had mentioned, hoping that we still have that on the agenda. It is. We will raise that one in October. So with that, again, thank you for everyone participating, listening, hearing, and we'll pick it up again in just a few weeks with another commission meeting. But before that, a conversation and a preview on the community engagement work that I mentioned earlier. So with that, hope you all enjoy the rest of your afternoon or evening, wherever you are, and appreciate everyone's participation again. Take care.